Here's our guest of honor, and I'm supposed to come and interview as well with him, talk to him. So I think you're behind. Is he behind the background?
Yeah.
Okay. Where do you want me?
You too.
Okay. You're here.
I'm there?
Yes.
Okay.
Go. I like it better in here because you don't have to do headphones and you can actually hear. And we're hot and ready to go. All right. All right. So we have Dr. Meeks with us. He's a sports medicine fellowship trained orthopedic surgeon. Just gave a talk in there about the posterior lateral corner. So Dr. Meeks, for those listening, explain what the posterior lateral corner is, because it's kind of that vague thing that matters, but we don't know what it is.
Yeah, it is very vague, and it has seems like hundreds of name structures, and I think that's why it's so confusing. So the posterolateral corner of the knee mainly consists of three things: the lateral collateral ligament, the popliteus muscle, and something called the popliteofibular ligament that attaches basically in between that popliteus muscle and the fibular head. And it helps to stabilize the knee to varus force and external rotation. It also adds to some stabilization of the posterior direction translation of the tibia.
Yeah, when you look at the anatomy, it kind of looks like where 290, 610, I-10 all come together there. There's all kinds of things right there, and it's hard to, trace back and figure out what's what sometimes, it looks like.
Yeah, it's extremely difficult, and that's why not only is it difficult to look at and think about, it's difficult to examine, and then based on a clinical exam, it's difficult to correctly predict what's injured and really what to do some of the time. So it's very important to hone your examination skills and to be very confident, or at least feel more comfortable in how to examine this part of the knee. And then also, everybody needs imaging and things like that to help them out.
So with that being said, with what we do, if I told you I went to make a cut and my knee popped, you're telling me I've torn my ACL without looking at me. I mean, that's pretty standard.
More than likely, yeah.
Is there, in your history with them, is there a statement that they're going to make to you that you would then hone in on a posterior lateral corner injury, or is it still a vague presentation from the patient itself?
For the most part, unless you saw the injury, it'd be a vague presentation. If they come into your office and say that their knee feels like it's buckling backwards, that may be a kind of a trigger that it's either a PCL or a posterolateral corner injury of the knee. One big red flag would be if they talk about the top of their foot going numb, though. And so that's an important nerve structure, the common peroneal nerve that comes around the posterolateral side of the knee. And if they're having symptoms from that nerve, then that would be probably one of the easiest triggers to, I need to go look at the posterolateral corner of the knee. So
this is one of those times where realistically MRI is an important thing to get to really ferret out what's going on.
Oh, it's huge. It's huge. X-ray for sure. Not everybody has the capability to do stress radiographs where you can actually look at joint displacement and opening. And so MRI is probably one of the most important tools in evaluating the corner of the knee.
Okay. So, and I'm going to say this because it's going to go into my talk later this afternoon, but you showed the picture of the Georgia football player with that lateral sided injury. To me, that's a knee dislocation. Would you disagree or agree with that?
Agree completely.
I think when you get a lateral side injury like that, that's dislocation until proven otherwise, and that's going to be multi-ligament in my opinion.
Completely, yeah. This an isolated corner injury only happens 2% of the time. So most of the time, it's going to have a concomitant PCL, ACL, some other ligamentous injury. And if you have two ligaments, then that was a dislocation until you prove it wasn't.
Right. It's going to have other CLs involved with it.
Oh,
depends on what the first letter of those are. Yeah.
Exactly.
Right, so in your talk, you talked about the dial test.
Mm-hmm.
I've never seen that. And then in that picture that you showed, there was two people. So does that test require two people, like one holding one leg and one holding the other, or?
It does when they're supine. And so, and that was the picture showed the patient supine, and you have to test it's testing the external rotation of the tibia and fibula at 30 degrees of knee flexion and 90 degrees of knee flexion. So it can be done by one examiner, but the patient needs to be prone.
Right. It's way easier prone.
It's way easier to do prone. It was just that picture that I'd found in the book was supine. And to do it supine and actually compare right to left leg like you're supposed to at the same time, then you have to have two examiners. It's impossible to do with one examiner and the patient supine.
Right, but
So can you talk me through that test?
Sure.
Prone, just so that if I want to use that, then I can.
Yeah, so you'd lay the patient prone, and then first you would have their knees, feet and ankles together, and then you'd bring the knees up to 30 degrees of flexion and hold both feet, and then you'd put an external rotation force on the foot through the ankle, and then compare the sides. And so as long as they're very similar and within 10 degrees of each other, then that test is negative. If there is 10 degrees greater external rotation on one side, then that side has a posterior lateral corner injury. And then you test the knees both at 90 degrees, and if there's a positive test or 10 degrees greater external rotation on one side, then it's a posterior lateral corner injury and a PCL injury. That test does not test for an ACL, but it does test for posterior lateral corner and PCL injuries.
So 30 and 90 similar to 0 and 30 for like an MCL, because if it opens at 0, you got an ACL with it type deal.
Right, exactly. And that's also a big test. Just your standard varus force test, not quite the not the dial test, but similar to the valgus test. If the knee opens to varus stress and in full extension, then you have a big injury. So you usually have a corner injury, cruciate injury, as well as possibly IT band and other things.
I've never seen an IT band damaged, but I guess maybe it's because I don't do surgery.
Well, it takes a lot. With us seeing a lot of the car wrecks that we see down in the med center, it takes something on that force usually. Usually not associated with sports, but with these things, you never say never.
Right. In all my years of those that I've examined acutely, I've had one that opened up, significantly laterally, that had a posterior lateral corner, but it was non-operative.
Yeah.
Immobilize and wait, and hurry up and wait, and it'll get better.
Exactly.
So, which you would think there would be more of them, honestly, from the sports we deal with, soccer, football, but it's not common.
Right. It's just not common. I mean, ACL, PCL injuries, and MCL injuries are all much more common than actually getting your posterior lateral corner. But when you do, you usually have to address it at the same time, or at least within the same treatment as you're addressing the other injuries, because forgetting about it and not addressing it, you just make other surgeries prone to fail.
When you let's talk about, and again, you talked about this, we're going to rehash it here. You talked about the care of that. Let's say Jeremy comes in and you say, okay, he's got a posterior lateral corner injury, but it's not horrid. He doesn't have, it's isolated. Mm-hmm. So, hey, life is good. So we're going to immobilize him in extension.
Yeah.
Okay. And for how long? Are we going to do anything with him? Is it going to be quad set, straight leg raise, or quad sets only? And because is a straight leg raise going to put any stress on that healing? I mean, those are.
It should protect it, actually. So
okay.
It's similar to a PCL injury in that the quad will protect it.
Okay.
So in the brace, quad sets, straight leg raises, but essentially immobilized in extension. They can come out with the help of a physical therapist to protect the injury. So, limit external rotation, limit varus stress on the knee, and then you can work on passive range of motion. But
we don't want to get them stiff, but we don't want to
get them too stiff, but you want to keep it kind of quiet for 2 or 3 weeks.
Right.
And then after 2 or 3 weeks, you can get pretty aggressive with motion, but again, protecting no external rotation, no varus force on the knee, just to help allow things to heal.
And kind of similar to a PCL, we would watch our active hamstring stuff.
Yeah.
Other than motion, once we're doing that, but anything resisted.
Right. Yeah, you limit your resisted hamstrings till the very end, and then after 6 weeks, most ligaments you would consider them healed, and then you start working on more active hamstring things.
This is not the injury that if you get it week 3 of the football season, you're coming back from to play typically.
No, not typically. Yeah, it's
very not at the high school level. Let's put it that way.
Very different from an MCL or a low grade MCL. It's very different from that. Different animal.
And that's a tough one to explain to coaches and players and parents that, well, it's not nothing going on. It's a big thing going on, but they don't understand that,
right.
It's not sitting off there dislocated or whatever. So
exactly.
Anything else?
Yep.
All right.
Other thoughts about things you didn't mention?
No. It's a scary injury in that it can have catastrophic complications if the nerve's actually injured. But if the nerve isn't injured, then and you address appropriate things, and they should have a good recovery and have a nice stable knee. And a lot of times the grade 1 and 2 injuries will heal on their own just because your body's great at healing things and lays down a lot of scar tissue and stabilizes itself. So we're lucky that the human body is such a miracle that all these things don't end up on our operative table.
Very good. All right, this is the sportsmedicinebroadcast.com/Evan Meeks. That's 2 E's. EVANMEEKS 2016. So that's where this interview will be. It's sportsmedicinebroadcast.com/Evan Meeks. Boa, thanks for running the interview. Dr.
No problem.
Meeks, thanks for being here and teaching us.
Yeah, thank y'all for having me.
All right. It'll continue to stream live.
So don't talk about this. What you're saying.
Yeah.
Or, whatever. You talk about the comment.
Thanks, sir.
Thank y'all.
Jeremy, you need to get him on. Okay.
Saying like during the year? Yeah.
Y'all run it up at the high school?
Yeah. That's where I do it most of the time. That's where I was
I
doing
think
it.
I remember seeing it like when I first got hired. I came out there and toured. I think y'all showed me kind of where y'all did that stuff.
Yeah, we went out there, looked at it. Yeah, we sat down. Did you get you on? Yeah. All right.
All right. Thanks.
All right, thank you.
Appreciate it.
So with like that, I get what was really nice. When you're listening to this, yeah, and so like right there, was that may have been me. Out there. So for whatever reason.
Having fun in here?
Yeah.
Ellen should be in here next.
All right, so this is Jeremy Jackson, Sports Medicine Broadcast. We're broadcasting live at the 15th Annual Sports Medicine Update. Just some quick reminders. Make sure you go to the website, School Health. You don't have to record. You get the next thing ready. So make sure you go to the website, sportsmedicinebroadcast.com. The School Health gift card, we're changing that. So it's every other month. We're giving away a gift card, so it's going to be worth twice as much. So make sure you register there, schoolhealth.com/SMB, and you have an opportunity to win the gift card just for being a listener. The more people that register, the more it looks, the more they're willing to do. So please go register at schoolhealth.com/SMB. And Nicole, thank you so much for being here running this. Nicole is right off camera, but she was on the interview yesterday, and she'll be a big part of what we're doing this week later at Spats. So she's going down to South Padre with me and Jasmine and Bubba. And we're going to be doing more or less the same thing. So, all right, I'll be in and out.
Unless you want me to interview you again.
Speak. Then you ran out. Okay, I gotta go. I gotta go to the operator. You're all right. Dr. Long, go ahead and have a seat in the hot seat over here. It's the one in front of the Memorial Hermann. Hey everybody, this is Dr. Josh Yellen again from the University of Houston Master of Athletic Training Program. We have commandeered the sports medicine broadcast from Jeremy Jackson. We are going to be in charge here for the majority of the day before I have to go and take care of some other personal things. So before, you guys just heard Dr. Evan Meeks, and he was talking about some epiphyseal injuries and really great information. And then we kind of changed a little direction. And with me today is Dr. Melissa Long, right? And Dr. Long is an athletic trainer at Foster High School. Yes. And that is in what?
Richmond.
That's
Texas.
in Richmond, Texas. And what school district is that?
Lamar Consolidated.
Lamar Consolidated ISD,
yes,
right?
Sir.
Because everything
Yep.
in Texas I've learned is an independent school district.
ISD.
Everything's an ISD. Everything is independent of one another. So, Dr. Long, your specialty is really in something really interesting, and I want a lot of athletic trainers to listen to this because it has to do with really where the profession is going in terms of legal, ethical responsibility. It has to do with outcomes. It has to do with policy and procedure. And so your specialty is really in
coordinated school health.
Coordinated school health. And for those that this topic is fairly new to, or they're not a high school based athletic trainer, or they don't do outreach on a daily basis, what is coordinated school health?
So coordinated school health is an overall model that connects things that are already active in the school that help students live healthy lives. It connects them overall, and it brings presence to the things that we do. Mm-hmm. So health education, physical education, the physical environment, the nutrition services, all the things that already exist in this school, the coordinated school health model is going to bring them all together and make it known that this is what we do for these kids every day.
And so, the athletic trainer, my understanding of coordinated school health, and again, for everybody that's listening, coordinated school health is pretty synonymous with population health. Isn't that right?
Yes.
Is it kind of one-on-one? So
yeah,
before
it is like population health, but it's directed just at the student. So we're not worried about the general population. We're worried about our student population. But besides that, it is the basic same idea.
It's population health in the school system.
Yes.
And so yesterday, I had the privilege of interviewing Marnie Collins Sims, an attorney with one of the school districts, and she was talking about different legal concerns in athletic training and in education. And we brought up the differences between HIPAA and FERPA and all those types of scenarios. And so this is the same kind of concept that if we look at coordinated school health and look at population health, we can start to make some parallels.
Yes, definitely.
Right? Okay. So for the athletic trainers that are listening, coordinated school health as it applies to athletic training, it's almost as if this was developed for athletic trainers.
Yeah, parts of it definitely. A lot of it deals with things that we do every single day. A lot of it has to do with how we keep our kids safe. It's all the first domain prevention of injury stuff, our heat policies, our illness, our lighting policies, our dehydration policies, what we do and how we do it before our kids even step foot on that field.
And so it's really everything, again, that first practice domain about injury and illness prevention and wellness protection. So you're talking about emergency action plans.
Yes.
You're talking about crisis intervention plans.
Yes.
You're talking about environmental plans.
Yes.
What about hydration? What about food? What about salt content? What about sugar content? Is any of that in there?
Yep, that's all in there. There's no one section of coordinated school health that addresses everything that we do as an athletic trainer. Instead, what happens in those 10 overall arching ideas that make up coordinated school health now, we are kind of sprinkled in all of them somehow. There's no one that just deals with us. We deal with something in almost every one of them.
And so this idea of coordinated school health, it started back in the 1980s with the CDC, isn't that right?
Yes.
And then they had a model.
Mm-hmm.
And then it moved like in the 1990s, and what is it, the ACSD?
Yeah.
What is it? Tell me a little bit more about the model that we have now that's coming out. This
Right.
new model is really based on
model.
what?
So the Center for Disease Control came up with this idea of coordinated school health. It had 8 components, and that was back in the mid-'80s. These components were trying to address the student as a whole. Their overall general wellness, their mental health, their emotional health, their environment. Is their environment safe that they're in? And it did a really good job. And then in 2007, the ASCD, which is the Association of Supervision for Curriculum and Development, so those are all those people that are worried about how kids do on test scores, they're saying they came out with their own little model with 5 parts to just say we need every kid to be challenged. We need every kid to be engaged. And so they still focused on the kids, but they were a little bit more vague. They knew what they wanted the kid to do, but they didn't know how to get the kid there. So the CDC said, well, our 8 components get the kid there. Your 5 components get the kid to do well academically. So we're all working towards the same thing. So let's join together. So they did. In 2013, they came to the table together. It took them a little while to get everything sorted out, which is understandable. And last school year, they came up with this new model. And we started to see it a little bit last school year, but you're really going to see it a lot starting next school year. And it's called the whole school, whole community, whole child. Sorry, it's kind of still a tongue twister because it's so new to me.
I mean, with all the things, before it was like No Child Left Behind.
Yeah, Race to the Top.
Yeah, now it's there's something about.
I don't even know.
Then there's this old math and this new math, and then there's this Rubik's Cube math, and I don't know. So now it's whole child.
It's whole school, whole community, whole child.
So we're really back to that holistic healthcare model.
Yeah, that we're going to hit that kid from every angle that they need help. Yep.
And so those athletic trainers that are interested in this, either because I would imagine that when this starts to come out, the NATA has got some really good information out there on secondary school settings, and they talk about everything from value models of the secondary school setting, athletic trainer, and what you do with the student aides, and all these different things. I would imagine that the NATA, as more information comes out, will probably start to take some of this, right? And there are going to be some articles written on it, and obviously you're the expert in this area, so I would imagine that you'd be leading the charge. And so there's going to be some information about, again, what is it? It's whole school, whole community, whole child. And so what does that mean? It's like, how is their home environment?
Yep. We're going to look at how we're not going to go into their home and check to make sure the bathroom's clean. It's nothing like that. But we're going to make sure mine either. We're going to make sure that they are safe. We're going to make sure that if they're not safe at home or outside of our school buildings, that they know that there's someone that they can go talk to about it, and confidentially too. We're going to make sure that the way they get to school is safe, which, is not just your school bus, but we're going to make sure that we're walking and biking to school, and that the paths that lead from these neighborhoods to the local school are safe. There's actually questions in the evaluation of this coordinated school health, the whole school, whole child, whole community. I got it backwards. But there's actually questions that ask, is walking and biking to school promoted? And if it is, are those bike paths safe? Are they monitored? Do we have crossing guards? They really do care about the kids outside of the school building as well as inside the school building. Because, and I'm not sure if you remember, it's a long time ago, but this Maslow's hierarchy of needs.
I love Maslow's hierarchy of needs, especially as it relates to education, right? And the business of what we do in athletic training, right? Nicole Cash is across from me, and she just graduated from my program, and she saw this in my administration class.
Yes. So then you all know, if we can't meet the students' basic needs, are they safe? Are they fed, which feeds into nutrition services, which is one of the components. Do they feel safe where they are? Do they feel I hate to say loved because a lot of people think that you shouldn't use that word in education, but I think that we should. Do they feel valued where they are and what they're doing? So these things are all really important. And without these things, they're not going to function academically, or they're going to function poorly academically. So in order to build up that bottom base of Maslow's hierarchy of needs, we got to have all these things that the coordinated school health and the whole school, whole community, whole child addresses before we can get up there to how are we doing on the STAR test?
Right.
Did we pass our end of course exam?
Right.
Because to me, I do care if you pass your end of course exam because I'm going to celebrate with you. But if you have other things going on in your life that need to be addressed before we even worry about the end of course exam, what if you haven't had a meal since Friday when you left school?
Right.
Then these
Right.
are things
what if I don't have a safe home environment? What if I'm on free and reduced lunch? What if I can't get to school safely? All of those things are happening just for me to get to school. And, when I get to school, I'm probably, as a student in that environment, just kind of letting down a little bit. I can't receive any information. No. I'm just happy that I'm here.
And safe and fed.
Yeah, safe and fed.
So these are all things these are some of the things. This isn't what totally it's about, but these are components of it. There's a lot more to it. It's a beast.
And so for those athletic trainers and those educators that are listening to this and they want to know more about it, you are presenting to a school district tonight about this, and you're presenting to Lamar.
I am. I'm presenting to my own school district. I've presented in the school districts before. Now tonight I'm actually presenting to our school board, which is it's getting big time. Someone's caring enough that the board is finding out about it and wants to know more about it.
And they're listening, and they're saying, look, we need to be able to take a better approach, because we all know in today's society, I mean, we are, unfortunately, I'm not going to get on my own soapbox, but there are some areas that are broken, and we need to be able to work together as a whole community, right? And fix it. So if somebody wants to learn more about this, right? Listening to your presentation, if you have an athletic trainer, somebody at the district that's just checking the boxes, right? Do we have an emergency action plan? Yeah, I'm sure we do. Do we have these things on hydration? Yep, sounds good. But there's no accountability. There's no assessment. So for those people that are saying, look, I need to get more involved. I want to get more involved because these people are checking the boxes on your behalf.
Yes, they are.
And maybe the person that's checking the box is an administrator, et cetera. But, Dr. Long, you've got credentials that you hold dearly, that protect the public and and that identifies you as an athletic trainer. If you are negligent in that practice, that exposes you.
Yes.
It maybe not expose the person that's checking the box, but exposes you and your credentials to practice. So what are some, if you can give maybe 3 major pearls of wisdom here, what are some tips that you would give somebody that I need to get involved in this? What do you want them to know?
So first off, I would tell them to go find out in their district about your SHAC. That's School Health Advisory Committee. They're required by law to meet 4 times a year. Some meet more.
And when you say by law, is that
It's
local law,
Texas
state law? So that's a state law. So it's not a
State law.
national law.
Nope.
So does every
Texas.
state in the country have a SHAC?
It varies by state. A lot of them do, yes, because it's a good model to follow. There's a few states that don't, and that's okay. They're kind of working out their own thing. But for the most part, there are SHACs in, I would say, at least 39 states.
And SHAC stands again for Shaquille O'Neal?
Yes, that's it.
Okay.
School Health Advisory Committee.
School Health Advisory Committee, so SHAC.
Yes, and it meets about 4 times a year, and it has people from the district on it, but it has a lot of parents. It has a lot of community members, a lot of clergy. It's supposed to have at least 1 clergy member. So it's bringing that community together, and they're going to talk about school health at that meeting. And
so if I'm thinking about school health, I'm thinking about healthcare professionals. So are athletic trainers supposed to be part of this committee, or?
Are we required to be? No. Should we be? Yes. Because we
is that
are.
Going to change? Is it going to be required?
In my school district next year, it will be required. And again, that's a district thing who's making it required. But I see us moving forward long term as yes, I think that either an athletic trainer or a team physician or maybe a school nurse is going to be required to be on the shack for each district. But when you get into these bigger districts, I know up in the Dallas area, a lot of the districts are one high school districts. So it's not that big of a deal. But down here near Houston, we have 4 high schools, 5 high schools.
And how many high schools are in your district?
We are opening our 5th this year. So starting this year, we're going to have 5.
So as a district, you've got to be able to coordinate 4, now 5 different schools.
Yes.
They all have to have the same policy.
Yes.
So there are going to be some uniform policies and procedures about, healthcare. There's going to be uniform policy and procedures about HIPAA and FERPA.
Yes.
There's going to be uniform policies and procedures about environmental conditions.
Yes.
And psychological well-being.
Yes.
And pre-participation examinations.
And these are all things that the shack committee is going to be involved with.
That's incredible.
So
that's incredible.
Being a part of your shack now is going to make it easier as an athletic trainer to get ahead of this.
Right.
Because if you, in about 6 years, when this is really going full steam, if you're like, wow, maybe I should get involved with my shack now, you're going to be behind the 8 ball. But if you get involved now, you're going to be leading the charge, which is great for you and what you have to do every day, but it's also great for our profession as athletic trainers to get us out there so that more people know who we are and what we do every day.
And you're really talking about, that first practice domain, right? Injury and illness protection or prevention and wellness protection. So that's nugget number 1 that you shared. What's nugget number 2 that they need to know? If
maybe you are too busy to get involved in shack, which is, I think you can make time for anything. I think you definitely need to find out in your district who is filling out that evaluation on you. Who is filling out what it's called the SHI, the School Health Index. It's hundreds of pages of questions about coordinated school health and how it's implemented in your district. And there is someone at your district that fills it out every day or every year, I'm sorry. And if you find out who that person is, offer your services to them. You don't have to go sit in their office and fill it out for them, but educate them on what you do every day because they're going to be surprised. My guess is they're going to be very surprised at how much of what you do is evaluated and what the district is held accountable for.
And now all of a sudden, because of your practice domains, right, your specialty, you become very, very valuable. And not only the school's eyes, right? If you are a high school-based athletic trainer and you're employed by that particular school, now all of a sudden your administration has targeted you and saying, look, you are really the expert in this area and we need to utilize your education and your services. And you become very, very valuable at this point, which, leads you down another road of, salary increase and all these other things. But you also start to become very valuable in terms of the school district size. You become very valuable in terms of the state's eyes. I'm sure at some point, hopefully, as far as a country is concerned, they'll start to look at this model as an entire country.
Yes.
And I can surely see you as a part of the president's council on this. I would imagine, and the only thing that I request is that when you do send a letter from the office of the White House, that somehow maybe I just get some sort of like, hey, I'm going to come pick you up in this
I'll send you a t-shirt.
Yeah, thanks. I'll send you a t-shirt. Hey, look, yeah.
I'm bringing Air Force too.
Yeah, I sent you this extra small shirt, fat guy in a little coat. Okay. And then finally, the third point is what? So right now we've got point number 1 is shack, right? Get involved in your shack. 2 is who fills out the SHI.
School Health
Index, right?
Who fills it out?
What's your third nugget?
I think my third nugget is that ask for help. You can ask me. My email's out there, my school district, my phone number, the whole 9 yards. It's all out there. But it's really confusing. If you try and do it, you go onto the internet, you start researching it. There's a lot out there on it. And it's really confusing. I mean, it's taken me 2 years to get to where I am. And still, there's sometimes I'm reading stuff and I'm like, wait, what's going on? So ask for help.
So people understand just your area of specialty. You are a board certified athletic trainer. You are licensed to practice in the state of Texas. But really your area of focus, your doctoral degree, really focused, your dissertation was on coordinated school health. So you are really the expert in this area. And so if somebody wants to learn more about it, if somebody says, hey, Dr. Long, I really I liked your presentation. I saw you at the Sports Medicine Update, or I heard you on the Sports Medicine broadcast. How would somebody get in touch with you?
My email is with my district is melong at lcisd.org.
And that's all one.
Yep.
So melong at
lcisd.org.
lcisd.org.
Or my personal email, which is a little harder, Melissa, MELISSA, dot Shaw, it's my maiden name, SCHAU, at gmail.com.
And so if they have some questions, they can reach out to Dr. Long. You can also look us up on this particular segment. It's going to be the sportsmedicinebroadcast.com, Melissa Long 2016. Again, that's sportsmedicinebroadcast.com. Melissa Long 2016. For this segment, Dr. Long, thank you very much for your time.
Thank you, Dr. Yellen.
And for the Sports Medicine broadcast, we have taken over the ship, and we have commandeered it, and we're going to drive this bad boy wherever we want. So for the Sports Medicine broadcast, this is Dr. Josh Yellen for the University of Houston Master of Athletic Training Program. Look us up, www.hhp.uh.edu/MAT. Thank you.
Thank you.
Bye.
Bye.
She's like that person in Star Trek. You know, look, look, Chief, you just sit in this seat and tell me where to go. I'll take care of the rest.
Thank you.
Hold on. Well done.
But all of the bright lights got me at first.
Yeah, but I think we're still live streaming. So like anybody that's kind of logged on to it at www.sportsmedicinebroadcast.com can hear this. Do I have stuff all over my face? Is that why you're there? You can barely see? Oh, there we are. Let me see your glasses.
Oh, that's really blurry. Actually, his microphones are blurry.
Okay. I'm still getting used to my bifocal. Oh. Yes, they're progressives. Like
When did that happen?
after you graduated, you beat me down. Before you came into the program, I had a full head of hair. I had no grays. I could see and I can hear. And after 2 years of just beating me down, Nicole, I now have a bunch of gray hair, a huge balding spot. I can't see and I can't hear. So thank you. My pleasure. So the next one is going to be Pediatric Cardiology and Athletic Medicine.
Unfortunately, we can't put our name down and give them our license number later.
I think Dr. Knobloch will interview is wait a minute.
Lorch Ozoude. Boys, we've met before. Yeah, don't worry. Good to see you.
Yeah, come on and have a seat.
There's a seat over there on the end down there.
at the end.
All right, you good?
Yep.
He's all yours.
I have no clue what I'm doing, by the way. So
What's that?
I have no clue what I'm doing. So tell me what to do.
You're a trained physician, aren't you?
Yeah, they messed up and let me in.
Yeah.
They messed up.
Do you
and let
have
me in.
any expertise in anterior knee pain?
About a day's worth. I think that's how long it took me to do the presentation.
Okay. Good.
Joking.
So let's start, shall we?
Sure.
Hey, everybody. Dr. Josh Yellen here again for the Sports Medicine broadcast. Again, we have commandeered the ship of the Sports Medicine broadcast from Jeremy Jackson, and we will be taking control for the rest of the day. With me today, or with me in this segment, is Dr. Ozoude, right? I'm saying that the right way?
Correct.
And Dr. Ozoude, George Ozoude, let's just briefly catch everybody up to speed. Give us a little bit of a background on you.
Sure.
Where'd you go to school?
Sure.
Where'd you do your training? And
Sure.
what do you specialize in?
Sure. Absolutely. I'm actually from Houston. I was born in Hermann Hospital, back when it was called Hermann Hospital. Moved to New York when I was about 4 with my family. And did school, undergrad there at St. John's, went to medical school and residency in Chicago, University of Illinois.
All right.
So I was there for about a decade, decided it was too cold, came down here to Houston for a fellowship, worked with the Baylor and majority the UT staff, worked with all the pro teams and UH and St. Thomas High School, and saw that this was the place I wanted to be to continue doing sports medicine. So
And so your training is in, you are primary care sports medicine, or you are orthopedic surgery? What's your
I
training?
am orthopedic surgery. So orthopedic surgery, sports medicine is about 50% of my practice right now.
Outstanding.
So we take care of 5 high schools in the Northeast area. So
Great.
Very fun part of the job. So.
And so your talk today was about assessment of anterior knee pain.
Correct. Yes.
And so we talk about anterior knee pain. What are we really talking about?
Oh yeah, it's such a wide range of different actual diagnoses that make up the whole entity of anterior knee pain. So, and it's very common. So it's just a very important aspect of athletes' careers. It's going to affect the majority of athletes.
And so when we really talk about anterior knee pain, obviously the hot topic out there is, ACL, meniscus,
Sure.
but people forget about the sesamoid bone called the patella.
Correct.
They forget about the patellar tendon. If you're really a true anatomist, you make a distinction between the patellar tendon and the patellar ligament.
Correct.
We look at how the knee moves and how all that other stuff works. So let's really talk about anterior knee pain.
Sure.
So what are, for all the people that are listening, what are some things that they need to know when you're assessing a patient? What are you looking for?
Well, first of all, I think you're right in kind of explaining how the perception is. We kind of see the acute injuries of meniscal tears and ACLs, but anterior knee pain can be just as debilitating and really keep athletes out of sports or performing at a level that's suboptimal to them. So I think it deserves a lot of attention. I think it has gotten a lot of attention because it's been so enigmatic, both the diagnosis and the treatment. Back 40, 50 years ago, the surgeries that were done on anterior knee pain were really surgeries that didn't help patients, sometimes made them worse. We're getting better. We're understanding more. We still have more to learn. I think a very interesting thing in more recent literature is how structures away from the knee, the immediate area of the knee, affect the knee. Posture, core strength, hip function, all of that positions the knee to be in a efficient position to absorb load. And once we get a good understanding of that, I think we can even make more headway.
And so we really kind of go back to what some of the topics were yesterday. We're really talking about holistic body movement.
Correct.
We're really talking about core strength. We're really talking about how the skeleton moves as one whole. We don't move segmentally.
Right.
We move as one whole. So start to categorize some of the injuries that we're talking about in terms of anterior knee pain.
Sure.
Because I think when people think about it, they think about, again, the patellar tendon, but what are the categories?
There's so much more. So we think we think about, we kind of categorize them into different anatomic structures. So there's bone. The bone of the anterior knee can either be the kneecap, the patella, the end of the femur bone, the trochlea, the very top of the shin bone, the tibia. Then we think about cartilage. There's the patellofemoral articular cartilage. There's cartilage in the meniscus that can be injured. And then the soft tissue, which is really should be the focus point, because in my talk, I indicated that a lot of the pain sensation, what actually is hurting patients, is actually nerve fibers, pain sensory fibers within the soft tissue. Things like the medial and lateral retinaculum, the patellar tendon, the anterior fat pad, or the synovial plica. Those are very exquisite, painful areas that can limit a lot of patients. Several other conditions can also lead to anterior knee pain. So referred pain from the back or the hip, still anterior knee pain, because it refers all to the front of the knee, and that's what the patients will come in complaining about. And it can be a head scratcher when you examine those patients and they have really underwhelming knee exams. Then you got to start thinking hip, back, something else.
So everything is being referred back to this. It's going up and down this kinetic chain.
Correct.
So when you're examining a knee, and we're really talking to the people that are listening. And so when you're examining the knee, what are some things, walk us through your kind of algorithm that you use when a patient walks in and says, "Hey, Dr. Ozoude, my knee is killing me.
Right.
What's wrong?"
So yeah, I think at that point, you just got to settle in, because you really need to be thorough. You need to start at the level of the history, start peeling away at the onion, asking questions about timing, onset, duration, location, understanding the anatomy, where certain structures are likely to hurt, understanding the nature of the patient's sport, their activity level, their goals, their how far they want to take sports. That can indicate how intense they participate. Asking questions about their surgical history, very important. Lots of reasons why post-surgical patients can present with anterior knee pain. Starting to think about the other areas away from the knee, ask about their back and their hip. Looking at risk factors, taking the patient and looking at what risk factors they may have for certain conditions, like certain sports or certain body types or certain ages, and female gender, as I noted in my talk, is a very high risk compared to males.
Is that because of the Q angle?
I think it kind of goes back to imbalance. I think that's the overall arching thing: muscular imbalance or structural alignment. So there has to be something that's conferred with being a female in association with some kind of imbalance that leads to abnormal loads and therefore leads to a pain. There's other, theories as well. There could be a hormonal difference too. So you try to look for reasons that can explain their symptoms. So
there's some great work happening out at the University of Southern California, and they were really looking at the forces that are happening especially on the medial side of the knee. And for a long time in rehab, or even prevention of injury, we gave a lot of focus to that vastus medialis and the oblique portion of that vastus medialis. And we looked at kneecap or patellar tract, and we looked at all these things. And ultimately, through some constant evaluation of metrics and outcomes and stuff like that, we started to see it's maybe more associated with that gluteus medius than it is more on that VMO, which I remember I was in school and I remember the shift happening, that all of a sudden we kind of went to a conference and it was VMO, stop.
Wait.
Gluteus medius.
Right.
And then out came, things like the functional movement screen, and then came, holistic exams, and then came that kinetic chain. And as my biomechanics professor said in undergraduate, Dr. Bill Whiting, he wrote a book with Zernica, two incredible biomechanists, about, Dizzy-Dean syndrome and this kinetic chain transfer, and, how if we have an issue in the big toe, it can transfer up to the, upper cervicals. And so when you're examining a patient, obviously we talked about history, huge component, your understanding of anatomy, even a bigger component. your understanding of where certain things can light up and where they can't light up. So now let's kind of move into a special test. Do you go through a specific routine in how you examine? So walk us through that.
Absolutely. So after kind of eliciting that history, I start my physical exam by observing. So I like to observe the patients while they walk, because that's just the natural progression. They're usually sitting in a chair, usually have them stand up to get over to the bed anyway. So I have them walk. I watch how they get up from the chair, what other muscles they may recruit, if they grimace, if they have pain. I observe any abnormalities in gait, look for any alignment abnormalities, any signs of weakness. I look what happens to their lower extremities once they become weight bearing, to look for any dynamic changes. Sometimes the navicular bone can pronate and can fall. And again, foot conditions has been, theorized to link to anterior knee pain. Look for any recurvatum in their knee with the gait cycle in the stance phase. And once I'm satisfied with that, I kind of look at things like the core strength. I think evaluating core strength in the standing position is very useful. And I do a bunch of tests. I literally have my patients exercising in clinic.
So a lot of what you're doing is a lot of what we're doing as athletic trainers in our evaluation process.
Absolutely. I think it's very important. And I think it's really important to say that and talk about it, because sometimes we feel as practitioners that we may not have the time, and we'll rush through some of these examples. You need to settle in and just take your time with it. So I'll have patients do a single leg squat, double leg squat. I'll have them do just single leg stance, just to observe how quiet they are with their control of their hip or in their core. I'll have them sit in a chair, scoot forward at the edge, and have them rise with both legs or with one leg, assisted with one arm, two arms, or no arms, just to see what kind of control that they have. Then we transition to the exam on the table, and then we go through several tests. And I like specific tests. I really focus on the medial knee. Okay. I feel like in my practice, the medial knee actually has is more common as far as location for pain. And I remember when I was training, and even personally, I remember being told for my knee pain that a lot of times it's due to tight lateral structures. This was back in the time when lateral releases were just the craze. I remember. Right? I was in school, and people were just. Everyone had a lateral release.
Yeah, I mean, if you had any if you had maltracking the patella, guess what happened?
Lateral release.
You got cut.
So I had a lateral release. I was in my first year of medical school, between first and second year, and I had knee pain. I was an avid basketball player.
And they came in, they cut you.
They cut my knee.
And how did it do for you?
I still have medial knee pain.
Right.
So it's really interesting, to see kind of the transition and see us grow and improve. But yeah, at that time, lateral knee pain was heavily pushed. The tightness of the lateral structures versus the weakness of the medial structures. My practice, I see the majority of anterior medial knee pain. So I think the medial plica is an underappreciated diagnosis.
And let's talk about plica, because I remember when I was going through school, and I think there are still some people that would debate it. Plica really exists in a structure that is intact.
Correct.
And once I cut that structure, the plica kind of magically disappears.
Correct.
Why? Why does that happen?
So yeah, when the plica is an embryologic structure, it actually
He's using big words.
And it actually is a lot larger. It's present in many people, but not in all. But it's a lot larger in almost everyone once we're in the embryologic stage and very young stage, and it recedes to a point where it sits just medial to the femur. Sometimes it can get thick and cause impingement, and I think not only does it have pain fibers, but it's also prone to scarring, and therefore removing it, trimming it, and receding it back to the medial gutter eliminates that source of impingement, and also treats some of those nerve endings as well. And that's where I think a lot of the benefit comes from.
Okay.
So special tests that I use for that, I really like to have the patient engage and activate their extensor mechanism. I think if and this is an extension, if they have pain, they will impinge right at that medial plica.
Right.
And then
they're gonna pinch it.
And I can even try to exacerbate that by 2 fingers, 3 fingers, just right along that medial condyle ridge. Just palpate along that area, have them go through a range of motion, have them relax their contraction. That sometimes causes a shift in the retinacular structures that will cause that patella to roll. They'll actually feel it roll a lot of times, and they'll say, yeah, that's it. That's what it does. It kind of rolls like that, and it's sharp pain right there. And a lot of times that just keys me into their medial plica syndrome. Again, it's something maybe that I'm biased to because I have them in both my knees, and I still, deal with them.
So do you give yourself like a local, and then you just start cutting on yourself, or?
Well, that's
thought about
one of the studies that I described was a guy cutting on himself without local. So it's interesting, and it's even underappreciated in the radiology field. You know, I come across countless MRIs after I order them and review them, and plica's sitting right there. Right between
and the radiologists,
joint.
They're just not trained to pick it up.
Normal knee.
Yeah, they're
normal knee, no abnormal findings. And I see a big old plica just screaming for help.
And so I like to chunk information together. Yeah. And so if I look at the plica, what other type of structures around the body? Like, to me, when you're saying plica, like platysma is kind of screaming at me a little bit.
Oh, really?
What other structures in the body, you know, might we see, so we can say, okay, the plica, it really has a tendency to act like this, and other structures in the body also act like this?
Oh, I think of impingement. So areas that can get impinged. So two harder areas between, or a softer area between a harder area. I think of femoral acetabular impingement. So I think of the mechanics or the kinematics of the hip joint as the hip comes up into flexion and pinches soft tissue such as the labrum or the capsule between the femoral head and the acetabulum. That to me is a similar situation where you get two bony structures impinging on.
So when people are really learning about, femoral acetabular impingement, right, they should really kind of take that theory and say, oh, plica is acting in a similar fashion.
Correct.
It's just not a true ball and socket joint. It's more of a hinge joint. But regardless of the joint, it's really acting the same way.
Correct.
Great. And so you've really focused on the medial knee. What other special tests do you use? Because right now, I mean, everything you're talking about is, for all the athletic trainers and physical therapists and, that are listening, it's like, man, your examination almost looks identical to what we're doing. But it's about your anatomy and being thorough and having this algorithm you're going to stick to, and right. It's about the process.
Absolutely. It's about being thorough and complete, really. That's what I would harp on. But additional things that I would use are ways to assess for contractures, imbalances. So I like to position the knee in extension or flexion, range it with the hip in different positions, maybe the hip in extension versus the hip in flexion. I think the hip in flexion changes the forces across the knee. It tightens the hamstrings.
Sure.
And that usually results in a different sensation for patients when they range their knee. I noticed that a lot of patients can get full extension if they're 45 degrees flexed. But if I put them of the hip, correct. If I get them up to 90 or more, though, they start feeling a lot more stress, not only in their hamstring, but in the kneecap.
Right.
So
because that hamstring is kind of pulling.
Oh, absolutely.
Right. And all that capsule is going to pull with it.
Right. And it's pulling on the tibia. So the knee and the extensor mechanism now has a stronger force to overcome.
Right.
Therefore, the pressure on the kneecap is just magnified.
And so
to overcome that.
Nicole, I'm going to defer over to you. When we talked about reliability and validity and specificity of orthopedic examinations, and we look at Lockman versus anterior drawer. Nicole, she just graduated from our Master of Athletic Training program at the University of Houston. And so we look at all that, right?
Go Cougs.
Yeah, go Cougs. And so, as we put that knee into flexion for an anterior drawer test, those hamstrings are really pulling on that tibia. We're not going to be able to get that anterior translation. But if we extend a little bit, slight flexion in that Lockman, we can really get that thing to move.
Absolutely.
And I think that people that are listening, hopefully they understand that, this is evidence-based practice. Why do certain things happen? Statistically, why are we looking at this? What are the numbers? What are my metrics? And hopefully everybody that's been listening over the last couple of days, they've really heard there's a lot of great information, but I love watching the show, The Profit. It's about business, small business, And Marcus Lemonis always tells the CEOs or the presidents, whoever owns it, you better know your numbers. Medicine is no different. You better know your numbers. You better know your statistics.
Absolutely, evidence-based.
So what is, what's your criteria now? So you and I are working together. I'm an athletic trainer, and I'm working with you. And, I say, okay, this is what I found, right? I've worked with you. I've used your protocol. Dr. Ozoude, what are some criteria of this is operable, this is non-operable? What are some indications and contraindications of why you're going to cut versus why you're not going to cut?
I think, again, this goes back to step one, understanding the anatomy, because that allows you to make an accurate diagnosis. That gives you something to go after with surgery. So that procedure that you do is not just an exploratory type of surgery and maybe a therapeutic type of surgery. You're actually going in there with a plan, a specific target, and a specific goal. And then the other things I look at are the whole picture, where the patient is at, because I don't necessarily advocate for just operating on the pathology as soon as it walks through your door. Yeah, they may have a huge medial plica, but that doesn't mean I need to go cut out that medial plica the next day. That means I need to fully work up any other sources of pain, see how conservative treatments work, because conservative treatments can work. So my threshold is after they've completed enough therapy and other conservative measures and still have symptoms that are limiting their return to play or their level of play. Because sometimes you can get them well enough to where they're happy and they may play with some level of pain in the anterior knee for the rest of their career, but they may be able to perform at the level that they want to. And that's a success. Pat on the back, high fives, even though they're not pain-free, they're still getting to their goals.
Functional again. They're able to they're highly functional in what they want to do.
Correct.
So it's really going back and following this conservative treatment pattern.
Sure.
It's this communication between physician and athletic trainer, and if it's going to be a physical therapist, and where are they? You're constantly assessing, you're constantly communicating, you're constantly updating, and your decision, it sounds like, is based on, are they able to be functional? Does it affect their activities of daily living? What are their goals? So let's say you're a 25-year-old athlete versus maybe a 65-year-old athlete, right? If it's a 25-year-old athlete, well, God willing, you've got another 60 years ahead of you. If you're a 65-year-old athlete, well, maybe we don't need to run the marathon anymore.
Correct.
And we can kind of calm you down a little bit, and we don't need to cut on you.
Right. And that's what goes back to my point about where's the patient. Where are they in several different facets? You have to treat the whole patient. And I don't, necessarily just look at a number and start making decisions. I actually think their physiologic age is important, and that, you can't really just quantify with a number. You really got to kind of get a feel of the patient. I've had, 50-year-old, 60-year-old patients that are just as active as a 20-year-old and 30-year-old. So I treat them a little differently than the 60-year-old who's more like 70 or 80. And, so that all takes into account, so.
Yeah. What you're saying is really, it's pretty interesting. Yesterday we had on the show, Dr. Kent, Michael Kent, and, he was talking about knee replacements. And so it's a lot of very similar type of, a lot of similar type of evaluations. It seems like everybody's kind of talking the same thing. We're really looking at, and the thing that impresses me about the whole group with Memorial Hermann is it's not this jump to cut, right? It's we're going to look at the patient, and if we have to bring into the operating room, we will, but hopefully we don't, and we'll see, right? And as orthopedic surgeons, obviously, that's how you all, right?
That's how we function. And the good thing is that we have good options. We don't, it's not like our options don't yield results. The options are good. The treatment options are promising. They're evolving, we're getting better at it. We're getting better. And that's going to be the shift to the future is preventative care and non-operative ways to heal. So once we do, in cases where we do have injury, we're looking at different ways that we can heal, as opposed to invasive surgery.
Did you hear what Dr. Ozoude said? The prevention of care and the athletic trainer's first practice domain is injury and illness prevention and wellness protection. And so for everybody that's listening, please, take note, take heed. Population health is upon us, and it's all about preventative care.
Absolutely.
And if we can prevent it from happening, we will increase our value. That spreads across multiple platforms, multiple domains. Dr. Ozoude, thank you, sir.
Oh, no problem.
For
Pleasure.
dropping knowledge.
No problem.
This
Glad
is
to be here.
awesome. I know where I need to go if I have anterior knee pain. If I'm not mistaken, are you doing no, you're not doing one of the breakout sessions.
I am not, no.
You got to get back to clinic.
Yeah, or cases today, and then
Yeah.
clinic for the rest of the week. So
Okay. Thank you very much
Thank
for
you.
your
No
time.
problem. Thanks you guys
Okay.
for having me.
All right.
Appreciate
Bye.
it. Awesome. Thanks.
Put in this is how the sports medicine podcast. Jeremy's going to kill me. Oh, yeah. Cool. I appreciate it. Yeah. Thank you.
Nicole, she just graduated from University of Houston, Master's of Athletic Training program.
Oh, right.
She's one of the students. She's
Where are you planning to go now?
I just got accepted into a residency program in Fort Worth.
Oh, excellent.
It's Texas Health Benjamin's full residency, so I'll do bone cancer analysis with motion capture.
Great, great. Is there any clinical aspect to that, or is it just all research based?
Yeah, there's the clinic, and then they have an affiliation with TCU, so I'll be at TCU, and I can pick a sport, and I think I want to do baseball and shoulder mechanics, so I'll be at TCU and then Texas Health Clinic, and then
Wonderful.
whatever they have going on there.
Wonderful.
Well, my wife tells me, like, look at that.
Oh, okay.
Okay. Yeah. All right. All set? Raj Shani?
Yes.
Yeah. Foot and ankle.
Foot and ankle.
Useful anatomy. Let's go to work, shall we?
Sure. If I sit right here?
Yep.
Great.
Right in the hot seat.
How are you doing?
Fine. How are you?
Good, good.
Josh Shani.
I think we met last year.
We did.
Yeah.
And you know what? I think I'm sending some students your way.
Yeah, I'm excited to.
You are?
Yes.
Good. I hope you are, because they are all in their second years, which means that they've had anatomy with me.
Okay.
And that's kind of a hybrid functional anatomy, gross anatomy. They get a little bit of cadaver. Then they've had lower extremity orthopedics. They've had upper extremity orthopedics, and they're in spine right now. So if they're going to be with you and you are foot and ankle.
No, I'm not foot and ankle. I'm just like everything. But I just did a talk on foot and ankle.
Right. Okay, so if you're everything, they should know everything.
Okay.
And so drill them.
Okay, I will.
Like, you're in clinic, you're in the operating room. If they don't know something, I'll give you my mobile device and you hit me up. You better. Because they need to study more. All right, we all set?
Let's do it.
Hey, everybody. Dr. Josh Ellen here again with University of Houston Master of Athletic Training Program. Look us up, www.hhp.uh.edu. I forgot to mention our last guest, Dr. Ozoude. If you want to look him up, that's sportsmedicinebroadcast.com / George Ozoude. That's OZOUDE, right? So it's Sports Medicine Broadcast, George Ozoude 2016. And with me right now is Dr. Raj Shani, right? And that's going to be the sportsmedicinebroadcast.com /RAJSHAINI. No, let me back up. My tongue is getting twisted. RAJSHANI 2016. Dr. Raj Shani 2016 Sports Medicine Broadcast. So, Dr. Shani, thank you very much for being with us today. And your talk specifically, and I kind of want to back up, give everybody an idea of your education, your training. So let's start kind of from the beginning. You are from, right, you went to medical school where?
I went to medical school at Baylor College of Medicine. I actually grew up here in Houston. I went to Memorial High School, so about 5 minutes away.
You're a local kid.
5 minutes away from here. Yes.
This is home.
This is home.
And so you went to high school here in Houston, and where'd you go to college?
I went to Washington University in St. Louis.
Oh, you went away a little bit.
Well, went away a little bit, but I had to come back to Texas.
Yeah, and then so you went to Washington University,
Right.
Great school, right? Great
loved it. Yeah.
It's a great liberal arts school. I love the liberal arts education because they teach you how to think. It's true. The liberal arts education teaches you how to think. For all the educators that are listening right now, we've gone away from that a little bit, and we need to teach people how to think again and come up with their own conclusions. But that's my own little soapbox. And so then you go to medical school where?
Baylor College of Medicine.
And so you graduate from Baylor College of Medicine, and you do your residency training
At UT.
At UT Houston.
UT in Galveston.
UTMB.
UTMB, yeah.
Yeah, great. I live in League City.
Oh, great, yeah.
We go down to Galveston all the time.
Yeah.
I love the beach down there. I'm originally from Southern California, so it's not Pacific Ocean, but I'm just saying. And then can you do something about the heat and humidity?
Oh, man. Working on it.
Okay, good. We'll make some phone calls, see what we can
And
do.
then I did my fellowship at Emory University. My sports medicine
So
fellowship.
you went out to Atlanta.
Yeah, went out to Atlanta.
And so did you have a chance to work with the Emory? They had a great fellowship program in athletic training.
I did. I was with the Emory athletic trainers, their fellowship there.
And was Forrest Pecha there?
No.
At the same time?
Not at the same time. Actually, just left.
He had just left.
Right.
I mean,
yeah.
Everybody knows Forrest. Forrest, if you're listening, he's now at St. Luke's in Idaho.
Right.
He is he a gem. If you don't know Forrest, you have to go look him up. He is the guru when it comes to athletic training residency programs. A lot of respect towards Forrest. Okay, so let's get into it. Your area, especially, is it your general orthopedics?
I do sports medicine.
Okay, and so the talk you gave today was about the foot and ankle,
right,
and about useful anatomy.
I wanted to focus in on the sports injuries that occur in the foot and ankle because they're often neglected for some of the more common knee and shoulder injuries. So we focused in on some of the more common foot and ankle injuries and what not to miss when you're examining the foot
And
and
so
ankle.
let's talk about it, right? So the common theme so far is you better know your anatomy.
Correct.
Right? Anatomy is key. Anything dealing with the body, your anatomy is your basis for everything that you're going to do. And so you know your anatomy, and now we're going to walk us through the history, right? Because I'm sure there's some sort of process or algorithm that you have in place that you always follow, and then start to make decisions based on that. Let's transition into some of the more common injuries and some of the special tests you like to use,
Right.
and then talk about maybe indications for surgery, non-surgery, etc.
Right.
Okay.
So the history always starts when you examine a patient. You always have to get a good history of how the injury occurred and what the chronicity of the injury. Have they been dealing with this for 1 or 2 days, or has it been going on for weeks? Does the pain that they have occur all the time, or is it only with certain activities? And if so, which activities? Is there swelling? Is it related to a certain time of day? These are all important activities. Also important what they do. Are they a weekend warrior athlete, or is this a high school athlete that participates in activity every day, and they are stretching their ankle in different ways, or for stretching any part of their body in different ways? So you want to get the clinical history of who they are, what they do, how the injury is occurring, when is it occurring, and if there's any contributing factors. Are they taking any medications, or have they done anything in the past?
Okay, so once you've got that history in place, let's start about the examination, right? And let's just, again, we'll just focus on, I know you're general, but we'll focus on your talk today, the foot and ankle. And again, for those that want to listen in, it's sportsmedicinebroadcast.com. Look them up, Raj Shani 2016, RAJSHANI 2016. So you've got all that history in place, and we don't really examine the patient until we've got all of that. And now we're going to start to get into our examination. Walk us through how you examine foot and ankle, and what is it that you're looking for?
You're examining someone as soon as they walk into your office. You're looking at their gait. You're looking at their mechanics of their gait. Are they limping? Or are they having what we call an antalgic gait, which is avoiding their foot because of pain, putting weight on their foot because of their pain. So as soon as they walk in, you're examining their posture, their gait, and how they're holding their extremity. After that, you wanted to examine just generally the inspection. Is there swelling? Has there been any bruising? Is there any gross deformity that you should be noticing initially? After that, you take them through certain physical exam maneuvers, whether it be palpation, looking for any swelling or any particular areas of palpation, or instability examinations. The most important thing that you want to notice on an examination is if there's any mechanical signs that you can elicit through a physical examination, that you feel a pop or crackers or crepitus, or there's some sort of catching or locking that you feel when you examine the ankle. Could be important to realize. A good physical exam also always includes the neurovascular status, testing the blood flow and the neurologic function of the ankle, the strength, if there's any decreased sensation, and so forth.
And so when we're looking at the different anatomical landmarks then we're just going to focus on the foot and ankle. Some things that pop out to me are, navicular, substentaculum tali, medial malleolus, lateral malleolus. So are there certain parts of the anatomy that you're going to focus on more than others in your examination?
It's all based on the history. We're coming back to the history. It depends on what the history tells me to look at. If the history is someone who's saying that I can't push off, well, then I'm going to look at the plantar plate and the first metatarsal a little more. If I'm having instability on the lateral aspect of the ankle, well, I'm going to focus in on that. If there's pain on the posterior aspect, we're going to look at the retrocalcaneal space. We're going to look at the Achilles tendon. Immediately, we're going to look at the deltoid. We're going to look at some of the posterior tibial tendons. I cannot emphasize as much how important the clinical history is, and based on the clinical history, focusing your exam. But then it's also important to take a step back and look at the whole picture, because there are contributing factors in. So we examine the whole entire ankle, but there'll be a focus in on pathology based on what the patient's telling me.
So for all those that are listening right now, I'm a big believer in, the process, and I like this system. It's called the Yale 6-step process of problem solving. And it's really talking about, as we apply it to medicine, we're going to go through this process. We're going to kind of go through this algorithm of, okay, we're going to make the examination. We're going to determine what the issues are. We're going to start to focus our examination. We're going to ask great questions to get to the area. And I'm going to know my anatomy. And once I have all that information in place, now I'm going to be able to make some deciding factors, right? And so let's talk about some of the more common injuries that happen in sport that you've seen.
With respect to the foot ankle, the most common injuries are the low ankle sprain. Low ankle sprains, high ankle sprains, Achilles injuries. They're all very, very common. Low ankle sprains are often treated with RICE protocol, but the main thing that you want to look at when you have a low ankle sprain is giving it the time and getting it back to where you want it to be and not going back too early to play. So it would be resting your ankle, getting back into an early weight bearing program, working with a physical therapist or doing a particular exercise, focusing on balance and strengthening of the ankle. And then if there's a clinical indication that there may be something more going on, you need to get that evaluated to look for any other concomitant injuries.
Okay, and so what is when we're talking about conservative evaluation, because everything that you're talking about so far for all the athletic trainers and physical therapists that are listening out there, boy, the examination that these trained orthopedic surgeons are going through is the same examination we're doing in our settings, whether it's going to be an athletic training room or.
In fact, you all usually the first person to examine and give us the idea of what's going on before we have a chance to examine the athletes. So the physical exam from you and from the athletic trainers is very crucial. In fact,
it's so important. I was just having a conversation with Brad Brown, and Brad, boy, he's got a wealth of experience. He brought up something really great. When he was practicing, he made it a point to go to every operation he could. Whatever, if it was an athlete of his and they were going into the operating room, Brad tried to get to that operating room. Why? Because he wanted to see how the surgeries were being done. He wanted to, constantly refresh and refine his anatomy. He wanted to make sure that he understood that, okay, when I go back to rehabilitate this injury, back from surgery, he understood the process. And the way I always describe it is, in orthopedic surgery, it's a lot like the contractor of the house, right? We're going to lay the foundation and we're going to build the house, and the structure is sound. And now we have to, kind of paint the house, and we got to put the drywall up. And that's where rehab comes into place, right? We got to start to make things move right and, all these different things. And so the more that we understand the procedure that the orthopedist is taking and the inside out, the better we are. And, you know, it goes back to this Institute of Medicine interprofessional collaboration is just huge. Okay, so now we're back and we're talking about that examination. When do you operate? When do you not operate? What types of things are you seeing? What's, you know, hey, I need to go into an operation because I saw X athlete and they got operated on, and how do you start to make these decisions?
That's a very tough question to answer. But first of all, I do want to reiterate, I think it's very important for athletic trainers to come to the operating room, because the operating room is an anatomy lab, essentially. You know, we can show you the anatomy in much more detail and show you the pathology. So if you do have that opportunity, I do recommend that. Now, coming back to your question on when to operate, honestly, it's tough to answer that question. It's all based on the individual athlete, individual problem itself. There are injuries that occur initially that need an operation. You know, tear your Achilles, or you have a fracture, or you have a significant Liz Frank injury. Those we know are not going to get better, and they need surgery. Now, the real question is what about these injuries that can heal but aren't healing, that may need to do that? So
what are some examples of those?
Chronic ankle instability, let's say, for instance, someone who had an ankle sprain. They've rehabilitated it. They're doing everything they can to get it better, but they still feel unstable on that ankle. And they've done the necessary physical therapy, and you have to give it. All clinical indications have to come together and say, okay, we need to proceed with this because you haven't improved after, let's say, 3 months of therapy. They've done the rehab, they've done the active medication, they've taken the medicines they need, and it's still not improving. Then it may be time to take the next step. It may be time to get more imaging and then take the next step. But it has to be delineated based off of what the type of pathology you have. Does it fall into one basket where it's an injury we know that's not going to heal, that needs, or is it just an injury where we have good evidence to show that in majority of the people they do heal, and if they didn't, we can look at some of those factors, whether or not address those factors, and if all of us fails, then move on to the last step. Surgery should always be a last consideration in those type of injuries. Yeah.
And so essentially, so now we're in the operating room, and you know, you've chosen, hey, you know, I need to go through the surgical intervention to get you to where you want to get to. What are some things that you want, you know, for all those that are listening, athletic training, PT, etc., when you're in the operating room and you release the patient back to us for rehabilitation, drop some knowledge on us about what you are expecting. What do you want to occur from us?
I think communication is extremely important between the physician and the athletic trainer. And I think it actually starts in the operating room, for them to be there in the operating room to see exactly what was done. Throughout the whole process, constant updates and feedbacks to see how the athlete is doing and what needs to happen. I'm a firm believer of being available through cell phone and through communication to discuss what's going on the practice field, because oftentimes the physician can't be there. So it's very important to get that feedback, whatever way you choose to communicate with your physician, whether it be through text, email, or through a phone call. Communication to get back and to follow the protocol that the physician has designed, to determine how that patient was healed and what's going to work for them. So communication is the most important, and communication every milestone, essentially. You know, we've set a milestone. We want the athlete to be here. Has the patient achieved those goals? And if not, why? What can we do to make it better? And you shouldn't feel any hesitancy to talk to your physician. That's what they're there for. They're there to communicate. They may be busy. They may have other patients to take care of, but you know, athletes are important to get them in, and you need to communicate with them.
Right. Any other pearls of wisdom you want people to know? You know, this is an incredible opportunity for us to come together as a medical community and talk and discuss and learn. What are some other nuggets that, you know, we can walk away?
I couldn't reiterate more of getting in the clinical and operating room setting with the physician, because once you know the paradigm of how your physician is approaching problems, you can apply that to the field, and you can understand how to treat the athletes better. So anytime you have the opportunity to get in the clinical setting or look at the pre and perioperative area of the OR, because I think athletic trainers get a great great training in the post care and the pre care, but that perioperative, what happens right before, what happens right after, that can be a little nebulous.
And I'm going to go off on a limb here and say, I bet you that mindset that you have was from your training from Emory.
Absolutely. That was a great residency. I really saw the trainers that worked there, that learned there, they really evolved from when they started to where they end. They became more astute of how to problem solve, how to diagnose, and how to treat patients.
And Forrest, he runs great residency programs. Again, he's one of those gurus out there that any questions I've got, I call Forrest. He's a great resource, and it's really one of the fastest growing areas in athletic training is the athletic trainer really functioning in a physician office. The athletic trainer really functioning in the operating room or in a hospital setting. All these incredible opportunities. I've got some former students that are gonna, they're gonna be in the operating room. They're gonna be first assist, and it's like, wow, this is incredible.
Right.
This is incredible. Well, Dr. Shani, thank you.
My pleasure. Thank you for having me.
This has been a real pleasure. Again, look us up, sportsmedicinebroadcast.com/Raj Shani 2016 for the sports medicine broadcast. Dr. Josh Yellen, University of Houston, Master of Athletic Training Program. www.hhp.uh.edu/MAT. See you later.
Thank you. That's a lot of fun. Yeah, great. So let me ask you this. Am I allowed to, or are we able to bring them to the operating room?
The answer is yes.
Okay. Yes.
Whatever you're comfortable with is
Okay. So can they scrub?
Yep.
They can scrub.
Go ahead.
They're familiar with scrubbing and knowing how to scrub?
No, you better teach them.
Okay. All right.
Yeah.
Do you know if they have gone through Memorial Hermann's credentialing?
I don't. They've gone through UTs.
Okay. That's what we'll probably need to get them into Memorial Hermann's credentialing.
Maybe.
So they can get badges.
Yeah, I know that. So last year, Nicole, who were you assigned to?
I was at UTO.
Did you go into the operating room? And it was just one of those things of, which orthopedist were you with?
He was the wrist.
Keplinger?
Yep.
Yeah. So Keplinger just brought you in. And you were there observing the surgeries.
Yeah.
Did you scrub?
His physician assistant, showed us how to do all that, but it seemed kind of informal.
But you weren't assisting or anything. You were just
Just there.
Yeah. So I think it's more of an it's whatever you're comfortable with.
Awesome.
And so this module, we're not doing from a program standpoint. We're not doing any formal assessments. So and the reason why is because trying to coordinate. It's a lot easier for me to coordinate with Gen Med and coordinate with like PT, the Ironman, because there's some consistency, clinic schedules, and I mean, you guys are changing all the time. It's too hard for me to figure out from an assessment standpoint. So the idea is that we'll assign them, and whatever. I mean, you want to get in there and hey, show up, and you're going to observe a surgery, and what's that, and what's this, and you better know it, and let them know that you trained at Emory. You're familiar with these residency programs. And
Wow, put them on the grind.
And I mean, if they don't know their anatomy, let me give you my card. If they don't know their anatomy, there are zero excuses for that.
Yeah, Keplinger, whenever he was doing the UCL surgery, he went in, he let us get really close and he would tell us all the anatomy and everything.
Right.
I remember that.
That's my mobile.
Thank you.
And then on the front side of that is my email and all that other stuff.
Nice.
And so whatever you're comfortable with.
Okay.
That's what I told Evan too. He's like, well, what do you want me to do? What do you want? Anytime you see a patient, throw them in there. We're going to the OR. Okay, come on, let's go.
The only thing that I will do in my office is having a little transition period. My assistant left, and so we're trying to leave before that. So it may be a little bumpy getting in from the side of the house.
Yeah, I mean, you got to the ship. All
right. All right, thank you.
Yeah, thank you.
Ow. That's awesome. Where am I sitting?
The one right in front of the banner.
Right here?
Yes, sir.
Okay. Hey, how's it going?
I'm Ryan Collins.
David Abbasi, how are you?
I'm a physical therapist out of Maryland.
Oh, cool.
Jeremy's asking me to kind of sit with you during the
Yep. All right, here we go. 3, 2, 1. What's up, y'all? Welcome to the Sports Medicine Broadcast. We're live at the 15th Annual Sports Medicine Update from Memorial Hermann. We were talking with Dr. David Abbasi. Congratulations. How old is your new baby?
Just over a month old.
Just over a month
Yeah.
old. Is that your first?
Second one. First one is about 17 months old, so.
Wow.
Yeah, 16 months apart. Yeah. Busy times.
23 months apart. But
Okay.
16 is
Yes.
real close. All right. So you talked about useful anatomy of
Right.
the shoulder, and this is a topic I really wanted to. I think it was designed off of my comments because that's actually exactly what I was saying. Whenever they do the, what do you want to hear about? Is like I just want to hear about how the doctors do the observations and the evaluations. So I'm really glad that you guys are doing that.
Right.
And there's a lot of stuff I don't necessarily need to know in the athletic training room.
Exactly.
It's maybe useful at some point, and so thank you for doing that. And it
Sure.
is real simple, and I'm looking forward to the breakout session. So I've got with me Ryan Collins. Ryan Collins is a physical therapist, been on the podcast several different times. One of the questions I have for you in your presentation, you talked about look for atrophy in the muscles. So when you're looking at the back, but with like a pitcher or a volleyball player, say their right hand, I would think that it's going to be larger on one side, right?
Well, if both sides, although patients do have, usually subtle strength differences, usually when you're at the level of the small, looking for atrophy of the smaller muscles in comparison, like the supraspinatus, infraspinatus, as long as there's not a nerve injury or a long time tear, usually you will not see that much asymmetry. When you're looking for those, like when you're looking for something specific in the shoulder, like suprascapular, infraspinatus, fossa wasting, as long as there's not an injury on the other side, although they may be dominant and quote unquote stronger, there will not really be too much of a difference.
Can you speak on potential asymmetries of like scapular positioning whenever you have dominant and non-dominant arms? So whenever you're doing like a scapular assessment,
right?
Sometimes you have a scapula that may rest a little higher or lower.
Right. So you can see scapular winging if you're looking for it in a patient, especially when they when you're telling them to do, go ahead and raise your arms up or abduct for me. What you can see sometimes is asymmetry of the scapulothoracic motion. So sometimes that can be caused due to scapulothoracic dysfunction or just long-time chronic poor mechanics or subtle, things, something that may have started as inflammation or pain. Patients started compensating. Now they have poor scapulothoracic motion. So that's probably the most common cause of when you see asymmetry in their motion. Another thing can be if they have, flat out scapular winging where you have like a nerve palsy or something like that. So that can be either due to long thoracic nerve issue or a trapezius issue, spinal accessory nerve, which innervates the trapezius. So you're looking for which way is the scapula not able to go, which will kind of clue you into that.
And so with the long thoracic nerve, you mentioned talking about the serratus.
Correct. So that'd be the serratus anterior. So the serratus anterior would pull the scapula when it's working inferior and lateral. So so patients with that palsy will have a scapula that appears more higher and medial. As opposed to patients with a spinal accessory palsy or trapezius dysfunction, the trapezius is to pull it up and to pull it in. So they will have one that's basically down and out. So basically those two systems are working against each other. So when one is out, the other side, it's like a tug of war. The scapula will go in that direction.
And both will potentially lead to impingement issues.
Yes.
You're not having that upward
Correct.
rotation or the proper
Right.
movements.
Yeah. I mean, all these muscles with the rotator cuff muscles and the larger muscles surrounding the rotator cuff, they all work in concert to keep the ball centered in the socket and to have proper mechanics. So if you have a break in the chain, then you run into mechanical issues and you start getting these impingements and things like that.
So back to the atrophy part, if someone has a nerve problem
Yes.
or a long-term tear, like you said,
Mhm.
is that something that you're going to say, yeah, it's been hurting for 6 months or for a year,
Mhm.
that kind of thing?
It can be. Usually, you will not see atrophy from an acute injury. Usually, just like it's like a muscle. If you don't use it, you lose it, and it's not going to happen overnight. So, if you do see atrophy, then immediately you know that it's been going on likely for at least a few months. It may be due to either, when you see this, it could be either due to atrophy of the muscle itself from pathology, like let's say a chronic tear. So anything distal to the tear is not able to do its job, so it will atrophy. And the other thing that can cause atrophy is if the nerve supply to the muscle is sick or has a palsy or something like that, then you're not getting the proper nutrition and the proper signals to the muscle. So that's another reason why you would have atrophy. So basically, it's one of the two, either the nerve supplying it or the muscle itself has pathology.
Right. And then one of the things that you said to make sure you're doing was the supraspinatus test, where make sure it's at 30 degrees.
Yeah.
And can you explain
Sure.
that?
So the scapulothoracic joint. So the scapula comes off of the skeleton, and if you look at a coronal of the glenoid, so the glenoid will actually angle anterior from the rest of the scapula at about 30 degrees. So it basically aims everything anterior, so our arms can work out here in front. So when you're doing that, you want to test, if you want to truly get the muscle straight and test it in a direct line, you want to put it in that same angle.
All right. So what happens if you do it at 90 or?
I mean, I think you're still probably testing it, but you're probably getting more, sneaking in of like now you're going more deltoid or, trapezius, things like that. So you just want to, the same reason, like if I want to test a straight leg raise with your quad, I put you straight up and down. We do it straight ahead. We don't test it at like 45 degrees of abduction or something like that. Same concept.
How about a case study?
Okay.
Common things you'll probably hear. How about a thrower comes into you and complains of repeated dead arm issues? It's the first thing you're going to look at, and how you're going to examine that person, because you'll see that throughout the season.
Right. So again, you always want to keep in mind, is it usually with a thrower, the main thing I'm keeping in track is a lot of throwers that have been throwing competitively for a long time. I'm basically counting in the fact that they most likely have like a chronic labral tear. A lot of them will have the internal impingement, which means once they get to that 90-90 position in abduction and external rotation, they're causing impingement of the greater tuberosity and the undersurface of the supraspinatus on the posterior superior labrum. So with that, you're going to have this chronic, what we call peel back of the posterior superior labrum. And you'll also get undersurface rotator cuff tears. Now, we also know, because of this repeated motion, so a lot of quarterbacks and again, these throwers may end up getting these posterior labral tears, and they can also develop paralabral cysts. So you can get if you have a cyst that develops over time, it can start causing impingement over the now this is getting more complex, but it can cause impingement over the suprascapular nerve, which kind of runs very intimately on the posterior aspect of the glenoid. So all things that could be happening. And usually that will, these patients with the internal impingement will also have GERD, or GIRD, for glenohumeral internal rotation defect. So you place their arm, again, you test them up in that 90-90 position, and you want to check what is their external rotation and their internal rotation versus the other arm. Usually you'll see increased external rotation and decreased internal rotation. So you want to, usually start treating that with a sleeper stretch or, stretching of the posterior capsule.
So what about the cases of a thrower
Mm-hmm.
who's been playing for a while and has the anatomical adaptations that's improved their layback, which is common for throwing? You're going to see a change in internal rotation regardless.
Correct.
Due to, even though you have a total motion that's equal to the other side,
right,
you may still see lack of internal rotation.
Correct.
Speak on that a little bit.
Yeah. So I think that's expected to see. I think we should always try to, however, maximize the internal rotation, because what happens is when you have a internal rotation defect, and due to the tight posterior capsule, that's only going to accentuate the internal impingement. So because of that tight capsule, when you're getting that 90-90 position, you're even more going to impinge that greater tuberosity against that posterior superior labrum. So it makes it worse. So we can improve that with just, physical therapy, stretching out the posterior capsule, knowing that it's probably not going to get to where the other side is, but even by maximizing it a bit, those symptoms can usually get really calmed down, along with rest as well. You can't keep, beating it up while it's in pain.
Something that you said in there was it's important to know internal impingement versus external impingement.
Right.
Can you speak on that?
Sure. So the most common ones that I think people are probably familiar with is, I think they just kind of call it impingement, would be the subacromial impingement. So again, the concept that you have different compartments of the shoulder, being the glenohumeral compartment separated by an intact rotator cuff or supraspinatus, and then you have the compartment above that, which is the subacromial space between, where the bursa is underneath the acromion. So external impingement, meaning external of the glenohumeral joint, also is known as subacromial impingement. So usually in that, it's probably the most common, and usually patients that are a little bit older, I'd say above the age of 40 or not throwers. That's what we're testing for, pain with overhead motion at the greater tuberosity. You'll have that Neers or the Hawkins signs, which will be positive. Passive elevation of the arm above 90 degrees, and you're causing that, you're basically jamming that greater tuberosity up against the undersurface of the acromion. So everything up there is going to get jammed. So that's external or subacromial, basically external of the glenohumeral joint. In comparison to internal impingement, which is on the inside, or where the internal or the glenohumeral joint is, when you get in that 90-90 position, imagine now the greater tuberosity and the insertion or the undersurface of that supraspinatus rubbing against the posterior superior labrum. In that position, that's what we call internal impingement. Yeah. So it's an anatomical difference in location. And that, again, is usually we're testing for that, again, in usually you only see it as an issue with throwers or people with posterior tight capsules.
So speaking on throwers, you keep mentioning the posterior capsule being tight.
Yeah.
How about the alternative posterior cuff tightening due to
Sure.
the eccentric stresses?
Yes.
Can you get the same sort of reproduction of symptoms with a tight posterior
You
cuff?
can, and usually it's not all one or not all one of the other. It's usually a combination of both. Basically, tight. Consider it. I kind of consider it tight posterior structures. So when you're going to treat that, luckily you're treating for both anyway. We want to increase internal rotation and the laxity of the capsule in the back, along with kind of stretch out those posterior cuff muscles as well. So you're kind of treating them both, but I think they're kind of a spectrum of disease with both of them being involved.
In there, you mentioned making sure you stabilize the scapula when
Right.
you're doing like the 90-90,
Right.
90 degrees of 90 degrees
Right.
of abduction, 90 degrees of external rotation.
Right.
How do you do that?
Okay, so first thing you want to do is use your eyes. Usually you'll be able to see them cheating, or that scapula just going moving much more than it should. The other thing I do is I literally will test them by first I will take one of my arms and I will hold down their scapula, and I will hold it tightly and I will not let it move. And basically I will test them in that 90-90 position in the internal and external rotation, and really try to keep the scapula as stable as possible. And then you want to use that contralateral side as kind of a comparison of what's normal for that patient. But that's I think if you really want to test it accurately, you really have to hold that scapula down, because it can have a lot of compensation and they can actually move through their scapulothoracic joint if you're not doing that.
So since we lack the visual on the audio part, can you
Right.
describe what you mean by holding it?
Sure. So what I'll do is basically take maybe my left hand and put it across their trapezius with my palm, and then I'm with the front of my fingers, I'm probably holding down that clavicle, and my posterior fingers I'm holding on the edge of that acromion. So I'm really trying to lock that scapula down, if that makes sense. Yeah. Yeah.
I saw it. So
Right.
Now, whenever I talked about bicep tendinitis
Right.
or anterior shoulder pain,
Right.
some guys, they're really big on PRI or postural restoration. Do you have any idea what that is? About breathing patterns and normalizing breathing?
Not very familiar with that.
Right.
No.
Just because they said that they've had a lot of success with just training people how to breathe, relieving a lot of the
Yeah.
shoulder pain as well.
Right.
But
Yeah, I mean, I know there's a lot of people can have shoulder pain with just bad posture, and their shoulders sit anteriorly, so that may be a component of it, but I'm not too familiar with that term, but basically just treat it how I see it. If they're having, I'll be clued into biceps pathology. Usually, again, it's someone older than 40. Usually, they'll be very consistent saying it's anterior shoulder pain. Usually, it helps if you press on it and it hurts, right in that inner bicipital groove. And then usually they do very well if it's truly coming from the biceps tendon with an injection in the office into the bicipital groove. I usually do that under ultrasound, and I like seeing the medicine go into that groove and kind of lifting up the transverse humeral ligament on top of it. And usually they'll report pain resolution pretty quickly if there's lidocaine in the injection.
Going a little further into surgery, your thoughts on tenodesis versus tenotomy?
I think it depends on who the patient is. I think it depends on the physique of the patient. I think patients that are, somebody that needs like a revision slap tear or something like that, something where you're not going to get a good slap repair. Younger patient, one with a active lifestyle, good physique, things like that. I think they are more appropriate to do biotenodesis on. If I have a patient, usually you'll have biceps pathology with rotator cuff tear. So we do it a lot while we're doing a rotator cuff repair. We'll also sometimes have to address the biceps if there's pathology there. I think for patients that have larger physiques, or maybe not the most fit, maybe a little bit obese, or the lower demand patients that maybe are 75 years or older, that don't do a lot of lifting, or don't care too much about cosmesis, the biceps tenotomy actually does pretty well in my experience. You can get your own set of complications from doing a biotenodesis. You can place them too tight, you can get hardware issues. So I usually reserve it for the younger active patient with higher demands. Otherwise, I'll do the biceps tenotomy.
So for a thrower who needs that anterior stability,
yeah,
would tenodesis ever be a?
It's a really tough issue anytime you talk about doing any surgery on a thrower. Where I trained, they used to take care of the the Marlins down there. We took care of Florida International University. One of the things that still resonates with me is, Dave, if you want to make sure that a pitcher never goes back to throwing, operate on his shoulder. So you really want to try to avoid operating as much as possible in pitchers, especially for slap type issues, because they need that looseness or that increased mobility of that shoulder, getting that external rotation. So if you tighten that back down, you may really be kind of limiting down their external rotation that they've kind of been used to their whole life, and now you have a mechanics issue. So I'm very, very unaggressive with operating on pitchers' shoulders, at least when it comes to repairing. Now, if you had like something like a flap tear or something, I think debridement probably would be more conservative. I think the more conservative you can be, the better. But usually I'm very careful about doing any type of a repair on a pitcher, even though they may have pathology, because believe me, if you get a high-level pitcher and you MRI all their shoulders, you're going to find a lot of stuff. So if you go operate on all of it, you're going to really, I don't know if you're doing the right thing necessarily.
Right, and then you said to test internal or external rotation. I didn't write down what you said. You're testing them straight here at the side with their the elbows by their side,
Yeah.
straight in front of them. Then you're really testing something else.
Well, not so much, but again, it's just the same concept of, because the glenoid is anteverted at about 30 degrees, I try to just put everything at that 30 degrees and be consistent. If you do it with the elbows to the side, I'm sure you are still testing it, but you're probably getting a little more pecs involved, or adduction versus internal rotation, at least going inward, and then going outward. Again, you're probably getting more deltoid in there than some of the smaller muscles of the rotator cuff. So everything for the rotator cuff, I think you should be testing at about 30 degrees anterior to the lateral plane.
It's definitely helpful knowledge, because I get the same. I've always tested them
Right.
straight in front, but now if I can have more accurate tests.
Right. Right. Yeah.
Useful anatomy, useful tests. So.
I appreciate it.
Anything else? Dr. David Abbasi. You got a breakout session I'm going to try and live stream that as well.
Okay.
So people can see that. But
Awesome.
Thanks so much for being on the
My
Sports
pleasure.
Medicine. This will be sportsmedicinebroadcast.com/David Abbasi 2016. And for the record, spell your last name.
It's ABBASI. So A B and B as in boy, B as in boy, ASI.
All right. I have to double check because sometimes I switch those when I'm typing it or tweeting it or
Yeah.
whatever. So I put two B's instead of or two S instead of B's. So I have to make sure I got that right. It's in there, right? It's actually written wrong. It's written wrong on there. So it's ABB.
ASI.
Okay. Yeah. I copied it off of there. I was like, I swear I checked it. And you said it. Okay. Because I think I remember looking on Facebook and it was that way and then seeing it there. But good. One more time. Spell it correctly.
It's David Abbasi, ABBASI.
All right. There you go. Straight from the man. Thank you, sir.
All right. My pleasure. Thanks, guys. Cool, guys. Thanks. Appreciate it. Thanks for your help.
Thanks, Ryan.
Thank you.
Yeah, thanks, man. You look great. What are you doing tonight?
Yeah, taking advantage.
See what it's like to be on the other side? Listen and learn and grow.
I like to get something. You gotta come away with one or two tools. That's what it is.
What a great, incredible. I hope everybody's so excited. I hope they understand. Like, I hope they're not here just for the seniors. I hope they understand, like, this is a chance for me to get better.
My personal opinion is I think they need to do a longer breakout session and more often. You can get so much listening, but then the application of it. Like, I cut mine down to like 15 minutes of talking and you said, all right, this last 5 minutes, let's just practice what I talked about. You know, that way, through application, you can ask a question, oh, was my feet working? Are my feet here? You know?
Too, is that I bet you if we did an assessment of how everybody in the building learns, I bet you it's most of the kids.
Well, yeah. I mean, thank you.
That's why you are
replicate
the
that.
profession that you're in.
Exactly. You can replicate it. If you can replicate it, you can teach it better. Right? Versus just trying to recall what information you're in.
Yeah, and it's, you know, I mean, I'm just going down this list and it's like, wow, incredible just to be around this many brilliant people, you know, and what it does is that it confirms my role, right? My role is to run this MAT program and build it and to provide all these opportunities. And I don't need to be great at all of this. I need to be great at my job. And the way I describe my job is I'm like the general manager of the business, right? Okay, we have all this in place, and I'm gonna go find the very best I can find and put them in place. Go. I don't need to know your expertise because I got you. Right? I can. Right.
I think honestly, that's how a lot of the medical field and profession can come along. And specialists. You need specialists who understand the specialists. You don't want to jack of all trades trying to run trees, and then you expect a specialist. But specialists aren't paying the risk. I mean, you guys have been talking about this one whole thing. At a next level of care, needs to understand that really the entire situation instead of just saying, yeah, I remember a little bit about the hand and the 6 tunnels, and I think I'll look up and follow the protocol and not have any sort of application.
To me, it's as I narrow down more and more my area is obviously the business of education. I love all the accreditation standards. Knowing all the different laws and regulations and that. And I also love the business of what would be the admin side of medicine. Yeah, and that's the thing is that we all kind of come up through similar training, been around different things, and we have to be able to respect the fact that what you're interested in and your training is different than mine. But it doesn't mean we can't work together. It means that we just have different goals. And you know, it's when I was getting my doctorate, one of my faculty really big into studying. I enjoy leadership. This person just in terms of the network of SEALs and so when they talk about the different SEAL systems,
really interesting is each seal, although they have been through seal training, they are very specialized. They know, what you and I, they're not, you're kind of, this person specializes in communication, this person specializes in geography, this person specializes in counter opera, this person, right? And it's like, yeah, you're working on each other, and you know how to function, but you're not all the same. You all are part of this team. It's scary to think about it because you do somebody, right? You're average at it, and you get into those situations. And that scenario is brought up. Let's say that you have a seal that specializes in specialized work, and they're lost. Okay. Now, what happens if there's a sniper attached to a safety? Okay, what happened to your overhead? Now, well, can you? Yeah, I'm not. No. And so it's really just fascinating. All right, next speaker, if you want to jump in. He's talking about specialties, and this. Yeah. Yeah, I don't even know some of the chart positions that they can handle. That's it. That's what I remember. Get the I run through the presentation.
What's been happening? It was a nice slow week last week, and now this week is busy. Yeah, going to doing the podcast down at Spats, so leaving Thursday. Oh yeah, we went last year Spats. I like it. I like going to that little conference. Yeah. And
go ahead and sit in the hot seat.
We're not going. We're not going this year. Is that sit right here? This one?
Yeah, that's it. You're not going this year because they won't let you back in. There are pictures of what happened last year.
Yeah, no, that was several years ago.
We won't speak of that.
That's several years ago. That's with me and Josh Woodall.
Yeah. Yeah.
Don't say anything else.
We have pictures. My son just got his driver's learning permit.
Are you scared?
No. No, why should I?
You one of those breaks on the other side on the passenger side.
No, man, you take enough medicine, you're good. I'm around enough physicians. Hey, everybody, we are back. This is Dr. Josh Yellen with the University of Houston Master of Athletic Training Program. Look us up, www.hhp.uh.edu/MAT. We have commandeered the show from Jeremy Jackson. We took this over yesterday. I'm like Pirates of the Caribbean. I took over the ship, and we are in charge.
Okay.
And we are sailing the Black Pearl. That's what we're doing. And so we're going to go a little bit out of order because we're going to get into some breakout sessions for everybody that's listening. And so in today's presentation, a little bit later down the road around 3 or 3:30, I have to leave a little bit early. So I wanted to interview you.
Okay.
With me to my left is Chris Shattuck. And you can look up this episode at www.sportsmedicinebroadcast.com /Chris Shattuck, SHADDOCK 2016. Chris Shattuck, sportsmedicinebroadcast.com, Chris Shattuck 2016. So, Chris, as always, GQ, I'm going to put up the picture that we took today. And
Okay.
I'm going to tag you on it because when I woke up this morning, I knew I was going to see you. And I thought to myself, I have to outdress Chris. And so I failed.
You did. You did.
I just can't touch it.
Well, I read today that it was dress casual. I didn't read that till today.
Yeah, I mean, this is
I
casual
didn't-
for Chris.
No,
I mean, I'm surprised he didn't show up
absolutely
in a
not.
tuxedo. But I'm willing to bet that you don't have socks like that.
No, mine are less.
Oh yeah, you have boring socks. I have to be able to claim a stake in something, so I claim a stake in this. So for everybody that's listening, hopefully Josh Will is listening. He was on the show a little bit ago. We were talking about legal and ethical regulatory concerns in the secondary school setting.
Okay.
And we talked about student aids, and we talk about.
I listened to the show.
Yeah, and we could talk a little bit about that too. But your talk today is something that I'm passionate about, and it's about administration and promotion of athletic training and your program. And when I think about Chris Shattuck, I think about somebody who is professional, somebody that acts the part and looks the part, and can represent our brand the right way, and is able to function in the community, and all those incredible things. People need to understand the business of what it is that we're doing. So, Chris, let's just have a little dialogue here.
Well, that's what I go for. That's you are representing yourself and your profession every time you go out there. And I like to say, and I'm going to say it today when I talk later, that being professionalism is not about do's and don'ts. It's about respect for yourself and respect for the people around you.
And so when you really, let's kind of go back. You've talked to our program before. We're going to bring you back again, and you have some of those do's and don'ts, right? That you talk about. You talk about how to be involved and where to be involved and all those. So let's talk a little bit about professionalism.
Okay.
Right. So in your mind, Chris, boy, we're here at the Sports Medicine Update.
Right.
This is a professional gathering.
It is.
Right. And we have all sorts of professionals with us. We have physicians, and we have nurse practitioners, and we have PAs, and we have athletic trainers, and we have physical therapists. And for all those that are listening right now or may go back and listen to this, I'm going to call some of you out, not by name, but look, I look around, and there are some athletic trainers in shorts and a t-shirt.
Yeah, that's right. And that's how they feel comfortable, and really being professionals about getting out of your comfort zone, representing yourself and your brand. Everybody's got their own brand. If you're dressed down, you're dressed in shorts and a t-shirt at conferences with your colleagues, somebody is going to affect your future later on. And they're going to remember you as that person that
that doesn't care about what they wear, about themselves. And that's how they're going to represent their brand or your school or your company.
And so, you know, along those lines, you know, when talking about the brand and talking about the image, you know, one of the topics that you brought up when you came to speak to our program was that athletic training really has an image problem. So
it does. I'm going over that today. Just a lot of points that that I talked to your students about, I'm going to hit today. And, you know, when you Google search images, if you Google search medical professionals, you'll see a lot of nice pictures, a lot of nice doctors, you know, nurses, whatever is that picture you're looking at right there. I like to think the lady in the front that's dressed business attire is an athletic trainer. But if you search on Google Images, athletic trainer, one of the top 10 images is that one of a girl in shorts and a t-shirt. And you can see that her clinic in the back, it's all cluttered with stuff. It's a bad image to have. That's what people think of athletic trainers.
And so, again, you talk about the image that we portray, not just in our own environments, right? But the image that we portray to our patients, right? You have some patients that are high school students. You have some that are college or professional. You have some that are police officers and firefighters, and some that are astronauts, and some that are in the occupational setting, and some that are, you know, all of these different things in different places. And we have to be able to, when we talk about image and professionalism, if we're going to live in this village of medicine, right, and that term and that concept is going to grow bigger and bigger and bigger. If we're going to grow, if we're going to live in the village of medicine, then we have to be able to act and behave and speak and look like medicine.
You do. Right? You do. I mean, you don't go into a physical therapy clinic or a doctor's office and everybody's wearing shorts and a t-shirt, or things are, you know, out of place. Everything's organized and it's clean. And you go in there, it's a medical facility, just like your athletic training clinic. It's a medical facility.
It's a medical facility. So let's talk a little bit about the professional appearance, because you're going to speak about this a little bit later today, and then people are going to be able to access this on, they'll be able to access your presentation, and then hopefully they'll come back and listen to this interview a little bit. And we'd like to be able to probably bring you on some more. So you touch on some things in terms of professional appearance, but there are a few things like, for instance, professionalism at work. And, you know, one of the things that I'll call myself out after listening to your presentation, one of the commitments that I made this year was, you know what, I'm graduate faculty, you know, for a professional program. So the days that I teach, I'm going to do my best to make sure that I'm in a shirt and tie. And that the days that I don't teach and I'm doing admin, with the exception of Fridays, because that's Cougar Red Friday. Okay. But the other days, I'm going to make sure that I'm in slacks and a shirt. I've got to be able to represent my brand the right way. I've got to be able to set an example. So you touch on a few points in your PowerPoint about professionalism. What can you talk about some of that now?
Yeah, really, it's just about, you know, looking apart, like you say. That's part of it. Keeping your clinic clean and organized. You never know who's going to come through the doors. Okay, my administrators come through the doors every now and then. My superintendent has been through there, and it's all unannounced. If I'm dressed down and my clinic is a mess, what are they going to think of me? They're think this is the guy we have running the show here. And I don't know if we want parents seeing that when they come in here to talk about medical issues for their son or daughter.
And so with your staff, right, every time I walk into the Dawson High School athletic training room, it looks put together, it's clean, it's neat. You all have your staff. And what's always amazing to me is that there seems to be kind of some themes that you guys follow. The last time I was there, I think Roderick and Gretchen were in a red shirt, but you were in a blue shirt. I'm not going to start to make judgments.
Well, that's, you know, it's red or blue. I've not been allowed to order white shirts until this year. So now I'll have a third color in the mix.
And so it's red or blue or white. And that's what you expect. And so we assign students to your location. We use you as a preceptor. And what are some of those conversations that you're having with the students, right? They come to you either as a first-year MAT student, or they'll be assigned to you for, you know, a semester-long or a year-long assignment as a second-year MAT student. What are some conversations that you're having with them as young people that are, very moldable, very impressionable?
Well, I let them know that, hey, I'd like you to wear slacks. I want our students, our athletes, our student athletic trainers, they're going to address you as an adult. You're going to be Mr. So-and-so or Mrs. So-and-so. They're not going to call you by a first name. And we had kind of had an issue with that early on, and because they're comfortable being called by their first name. We had to kind of get over that. I had to talk to them, I had to talk to our students. Hey, you're not going to address these people. They're adults. And then I kind of let them decide for themselves. I let them know, yes, I'd like you to wear this. I'm not saying these are rules. But when they come in that first day, and if they're not wearing slacks like everybody else, then they feel out of place, and they know, okay, this is what I got to do. And that's what I do with Roderick and Gretchen too. I never gave them, these are guidelines. You need to make your own decision and feel comfortable. They're professional too, just like me. And I think that might be one of the reasons we hired them. They were super professional.
Yeah, and that's a big component for a lot of people that are out there listening, especially for the young professionals just entering in the program. What you're doing now as a student is going to carry over to what you're going to do as a professional. People are going to notice one way or another. They're going to notice. Yesterday morning, Dr. Lowe kicked this whole thing off, and I forget the exact title of his slide or of his presentation, but he had this great thing like, "Don't call me doc." And that's a little pet peeve of his. And, it's kind of a pet peeve of mine too, of that, we all have individual names. We are all individuals. So one of the things that I kind of cringe at is when an athletic trainer, you are an athletic trainer assigned with a high school, hey, coach so-and-so. You're not a coach. You're an athletic trainer.
That's true.
Hey, doc, unless you've earned your doctorate. Okay, well, you're not doc. These are terms that we kind of attach to certain things. And so you talk about kind of know who you are, know what your identity is. What are some things that you implement at Dawson? And I'm going to keep on using Dawson as an example. My apologies to other high school athletic trainers. I'm sure Brian, not Brian, he's in Bryan ISD. I'm sure Josh Woodall at Bryan ISD. I'm sure your athletic training rooms are probably pretty similar.
I imagine they probably are.
Because you all trained together in the beginning.
Right.
And then you came down here.
Correct.
And so, tell us a little bit about your policy about identity. They're going to address you as Mr. or Mrs.
Right.
To everybody, you're Mr. Shattuck.
Correct. And that's just as part of it. Our students, our student athletic trainers right away, when we kind of go over our policies, everybody needs to have some set guidelines of what rules they should follow. They're going to address somebody as Mr. or Mrs. or doctor or coach, or, they're going to be respectful, because even that athletic training student aide, they represent you. What they're wearing, if they're wearing some real hoochie mama shorts and a t-shirt and they're going to work a game, for me, that's not going to look good for me. People are going to look at Dawson High School and say, that's what they're letting them do over there. So they have a dress code of practice and at games. Now, we don't keep them around. We'll give them maybe 2 strikes and then you're gone. Because if you're going to be making me look bad, I'm not going to keep you around.
Yeah. I mean, you're wearing my company logo, right? That's my brand.
Exactly.
And that's one of the conversations that I have with our students is that UH that's on your chest. That's my company. That's my brand. And so the example I always give is, boy, let's say you get hired by Toyota and you show up in a Honda shirt. What do you think is going to happen?
You're not going to be there very long.
That's right. You're probably going to get fired. And so then you talk about, okay, this is identity, make sure that you secure the identity, but really it's kind of like, who you know, right? And how can you use those relationships to leverage what it is that you want to accomplish? It's about marketing and promotion.
It is. The better you can make yourself look, and the more people you can surround yourself that believe in your brand, the more ability you're going to have to get things that you want. You're going to come into situations. Every situation you go into is not going to be perfect. You might like that situation. It's better than your last one, but it's never perfect. So how can you make it better? And you really need to be evaluating that on a yearly basis. How can we make things better? How can we make ourselves better? And one way to do that is to market yourself. And if you do that and you surround yourself with good people, then you're going to get things you want to accomplish done. If you want an additional athletic trainer, you need higher salary. If they believe in what you're doing, they say, yes, he makes us look good, they're going to be more than willing to help you.
And this is really kind of about the business. It falls into that 5th practice domain. And that fifth practice domain in this last cycle of the exam represented only 12% of the BOC exam, right? So that meant that 88, my math may be off, but 88% is really about clinical application, right? And then you've got this 12% that really falls in this fifth practice domain. Right now, it's organizational health and well-being and professional development. And it's going to change in the seventh practice analysis into healthcare administration and professional development. And it's really about the business of what we're doing. And, it's going to go to 13% of the exam. So 87% clinical application, 13% billing, marketing, leadership, all those different things. And it's a small percentage. And people don't seem to totally connect all the dots of how important this is. And it needs to start at a very young, with young professionals and for those that are involved in the clinical practice in these different settings. So tell us some of the strategies that you've used at Dawson High School, because you have been pretty successful. I mean, you came in with, my understanding is you came in one contract form, right? You're a teacher with a stipend. You changed that over to administrative. Is that right?
I believe when I came into Pearland, it was a teacher plus a stipend and extra days. And I really wasn't on the end of changing that. I think when I got there, that was already kind of in the process, but they got it changed to administrative. And I'm not saying there's good and bad for both. If you, especially if you like being in a classroom, there's several things you're doing in the classroom. A teacher might be a way to go. Just make sure you're getting compensated for those extra days and that extra time. Administrative, they can't put us in the classroom. We do a lot of administrative duties. I think that, when we do, say, a lightning policy, that's not just for athletics, that's for the entire district.
And that goes into, Dr. Long, Melissa Long was on here before about the coordinated school health. Part of that policy, like lightning policies, environmental action plans, heat illness policies, right? So a lot of what's happening and what you're talking about and what she talked about, boy, there's a lot of overlap there.
Okay.
And I mean, it's pretty impressive about what you all are doing. So let's stay on some of the other things that you've done at Dawson High School, because if I'm not mistaken, you are an NATA. They designate these schools like you are a safe
sports school. Yes.
Yeah. So talk about the process that you went through.
When this first came out, I really, I didn't know if I wanted to do this, because you do. There's a fee. There's like $150 fee. Okay.
And who paid it? You?
So we pay it out of our activity account.
Okay. Correct. Dawson High School pays for this.
Dawson High School paid for it. There's a list of guidelines that you have to follow. Some criteria. You check the box. Do you do this? Yes. Do you do this? Yes. Okay. We do everything on the list. So that makes us Safe Sports first team school. There's also a second team. I guess there are a few things that are not checked, maybe you're on the second team. But I didn't agree with it at first because you're paying to get this, whatever this title is, this Safe Sports School Award. But the more I thought about it, I thought, if we meet this criteria, and then my principal signs off on that, yes, we do these things. We do this. This is going to get us some recognition and help.
It's great marketing and promotion.
It
for
is.
Your program,
I thought that, and I thought, okay, we're going to time it up for National Athletic Training Month this year, and that's whenever we received the award was March, to kind of tie it in with everything else that we were doing.
And so it goes back to being involved, right? So at Dawson High School, we're going to have a code of professional conduct where this is the way we're going to act, this is the way we're going to dress, this is where we're going to address people, this is the way we're going to speak, right? This is how we're going to promote our brand. This is what we want to be able to represent, not only from Dawson, but for athletic training as a whole. And so, people really want to be able to make their situations better. And that leads me into my next question, get involved. You've been very involved.
Been involved, and I wasn't always involved. I think the first few years when I was an athletic trainer, trying to find my way, I was at a SWATA meeting. Josh and I were sitting in the
Josh Woodall, SWATA president.
Correct.
Yeah.
We were sitting in the Texas forum for SWATA, and we were listening to, I can't remember who stood up. I think it might have been Randy Matthews, and he just yelled at us and said there was a vote, and I think maybe less than 10% of people, SWATA members, voted. And he went off on us and saying how this is unprofessional and y'all are doing it wrong. And I really took that and I said, you know what, he's right. I need to get involved. I need to do more. And Josh and I talked about it, and that's what we decided to do, is just kind of get involved and see where it leads us. And so our first thing we did was we did our own website for Bryan High School. And then we had an opportunity to do Texas State Athletic Trainers Association website. So we took that on together, and we kind of kept it updated, and it kind of evolved from that, really.
And then from that point on, Josh went one path, you went another, right? Josh now SWATA president.
Correct.
And doing some great things in that organization. And then you took some other paths, right? You got involved in some other things. So what are some of the leadership positions that you've had?
So currently I'm a parliamentarian on the SWATA board.
Yep.
Robert's
Rules of Order.
Right. It's boring, real boring, but you hopefully can keep the meeting moving a little bit quicker. Another thing that I'm coming off of this year is the scholarship committee for SWATA. And then after I did, I guess right in the beginning, we did the TSATA website. I moved to Houston, and there was an opportunity for me to take over the GHATS website, so I did that. And I got a call from the SWATA district director at the time, Brian Conway, said, hey, there's a vacancy. Somebody had left a public relations chair for SWATA, which also makes you a member of the NATA Public Relations Committee. Would you like to do that? I said, well, I had no idea what I was doing. When I got there, I had really no information. So I had to kind of create what are we going to do as a public relations committee? And I think that really helped me learn how to market myself and kind of, my program, who we are.
And so for all those that are listening, right, you've got some athletic trainers that have been out there practicing for a while, maybe some new athletic trainers, maybe some students who just graduated or entering the profession. Give us 2 or 3 nuggets that we can walk away from that are important to you, right? What would you want people to know?
If you're coming out, you need to get involved right away. I think one of your students, Will Ryan, he's doing it right. He's involved when he's a student. He's on the student senate. He's looking at ways to get involved when he becomes certified, which I hope is
pretty soon.
Right now,
pretty soon. He took the test.
Okay.
I mean, they all took the test, with the exception of one. Right? We're all within a couple of weeks. We should know.
Kind of my pet peeve is you can't complain about your profession if you're not getting involved and trying to make changes and try to make things better. So you need to get involved. You can't complain about it. If you're okay with the status quo, then go on doing what you're doing. But like I said earlier, is you're going to come into every situation, every job you have. You might like it, but it's not going to be ideal. How can you make it better? So I think getting involved right away, even getting on a committee that's people don't pay attention to, and just being a member on it and seeing how things work, you can help move our profession in the right way, in the right direction.
And what's one other thing, right? So get involved. Make sure you stay involved.
Looking professional.
Look the part,
market your brand.
Market the brand. Know the definition of a certified athletic trainer and know those practice domains.
And get to know people. Just shake some hands. Talk to people. If you see a circle of people talking, go get in. Just go get in there and talk to somebody.
Grip and grin, right?
Yeah.
Grip and grin. All right. Any last words of wisdom for us, Mr. Shattuck?
It is about who you know. Somebody tells you otherwise, they're lying. It's about who you know.
It's about making connections, making sure you can get to the right place. It's that quote. I think it's either Benjamin Franklin, Thomas Edison. If I'm able to see farther, it's because I stand on the shoulders of giants. That guy right there is one of the giants. He really is. So look his interview up, his broadcast up, www.sportsmedicinebroadcast.com/Chris Shattuck 2016 for the Sports Medicine Broadcast. This is Dr. Josh Yellen for the University of Houston Master of Athletic Training Program. Look us up, www.hhp.uh.edu/MAT. And we will be back soon with our next guest, Mr. Shattuck. Thank you, sir.
Thank you.
Bye. How are you? Here's a little history lesson for you. You're wearing an Adidas sweater. Adidas is brother of who? Nope. No, Adi Dostler. Adidas. He had a brother, Rudy. Rudy started up a similar program, or similar company.
So I guess he's doing a yeah, it was because I went to high school and he was at like so I guess it was like just been kind of helping him. So just new? Well, I mean, because I played sports, so I was one of the athletes. Oh, so yeah, I wasn't one of his students. And I want to do athletic training. So that's why I'm gonna ask now, like, this is just fun to do, like, media stuff, or like, no, it's because I want to be an athletic trainer. So what are you doing right now? Like, I'm a kinesiology major at Hermann. Yes, I should be graduating next year. Yeah, we had 2 people come in and get a job there. I don't know if you're interested in our program. Yeah. Okay. Oh, and then you talked to him about it? Mm-hmm. Oh, it really is like people that I know should have gotten into the program that were like smarter, like they had better grades or whatever. Mm-hmm. They didn't get in. The people that actually talked to him and that know him, like Josh, mm-hmm. and who like told him, hey, I'm really interested and I'll like work hard for you. They got in, lower GPA, like lower GRE scores, but they just like talked to him. And he's more about that than he is about like, are you the smartest person ever? Like, nah, like he doesn't really care about that like at all. He wants to know that you won't like screw anything up. Like we're just talking about like his brand or whatever. Yeah. More concerned about that. It's like if you keep talking to him and you keep showing your interest. Yeah. Okay. I mean, this is my 3rd time coming to just this event. And I've helped him with the loose stuff. We'll help Jeremy with the loose stuff. And I was here last year? Yeah, last year and the year before. So I guess I met Dr. If you have his email, when you apply for it, it would be like next December. Probably like a year from now, you apply, right? So like a few months, I would say 5 months before, because 5 or 6 months before you like apply, just start emailing him like once a month. Just like give him updates, like oh, so much better. Or like just talk to him, and he'll email you back. That's the great thing about the calendar. He's always on the phone. It's like the bad thing, the good thing is he'll like reply to you. Yeah, he'll know. Yeah, that you. Yeah. So if you just do that, it'll make the process a lot easier to get into. I recommend that. And then you have Jeremy too to help you. Mm-hmm. Jeremy should write you like the recommendation. Yeah. Like every time I see Dr. Green, he's always asking, so you're going to apply? Yeah. And also you apply. Plus money. Money for it? Yeah, like everybody that applies brings money.
right, almost time for lunch.
Huh?
Almost time. Are you editing it?
Yeah.
How's it look? Okay.
Yeah, it's okay.
It's awesome. Come on. It's amazing.
Like you go to have lunch? Is that what it was? No, I would. Is there one more session? Oh, so like lunch is just.
Oh. Alrighty.
There should be a text message. Some things have changed. Don't have to. I'm gonna know. I'm waiting for somebody to take it over and put it back there. Just choose a spot. Wait, come a little lower. What? You got it.
Go to lunch. Going to lunch. Chilling.